I'm so happy to have this Gokulam CME, where we have distinguished faculties who have proved who is who in the pediatrics in the national level to share their expertise with us. So the first session is going to be by Dr. Nita Radhakrishnan, the consultant pediatric hematologist from Noida. She is our own alumnus, so I'm extremely happy to welcome Nita to this session. And to chair the session, we have Dr. Sankar with us. He's the additional professor of pediatrics in the Government Medical College Trivandrum, and he's also the consultant geneticist. Let me say he's the first person with the DM in genetics in the state of Kerala. And apart from all his academic profile, more than that, he's a friend of mine and always great support to us. So over to you, Sankar. I'm extremely happy to welcome as well as thank you for this meet, and then over to you to carry forward the session by introducing the speaker as well as the topic. Sankar, please.
Thank you, madam. I was very happy when madam told me to chair this session of Dr. Nita, because one side, Lalitha madam is my teacher and Nita is my student. Actually, Nita is our student. So many teachers are here. Nita's teachers are here. She is actually alumnus of Medical College Trivandrum. She done her MBBS in Trivandrum. Moreover than, she is the daughter of our own teachers, Girija madam and Radhakrishnan sir. And senior people knows, for youngsters, I want to tell that also. Madam was a cardiologist and sir was the anesthetist. And she has done MD in Pediatrics in IAP Medical College. When I was there for a short period, after in 6 months, she was done their MD in IAP Medical College. From there, she went to do her hematology training and fellowship DNB in pediatric hematology and oncology from Gangaram Hospital under Anupam Sachdev, as you know, it's a national figure. And she has also done a fellowship in hemostasis and thrombosis from University of Milan. So actually, she is a student of mine. At the same time, at present, she is actually, I will ask all my doubts in hematology as well as in primary immunodeficiency diseases to Nita only. If any doubt in flow cytometry or anything is there, she is immediately helping us. So thank you, Nita, for the continuous patronage given to the all Kerala faculty and medical colleges. About the topic, the CBC is always a very important thing a pediatrician should know, because evaluation of anemia is not like previously. A complete blood count, including the red cell indices and other factors, will definitely give you an indication that in which direction you have to go. I am very happy that madam has taken this topic, interpreting CBC in office practice. Over to Nita for these topics.
Thank you. Thank you very much, sir. And thank you, ma'am. And it's indeed a very big honor to be presenting in front of my teachers. A very humbling experience. I hope it goes well. And it's a very simple topic, but over the years, a lot of things have changed in this simple investigation. I hope in the next few minutes, we see how this can help us further in our clinical practice. So CBC is probably the most informative. It's a power-packed investigation. It's one investigation which gives us many variables. And from a single investigation, it has evolved to much larger scale. Although we cannot replace peripheral smear, but over the years, we have learned that a good analysis of CBC can help us make quick decisions in practice. So we are all used to looking at the hemoglobin, the RBC count, the WBC count, as in the white cell count, the differentials and the platelets. But if you can look a little further, you can start looking at RBC indices, the hematocrit, the platelets, not just the count, the platelet volume, the distribution width, and histograms. These information is always available in our Coulter reports. It's just that we are not used to seeing them. So as a practice, it would be nice to ask our pathology colleagues to give us the report as such, and not the printed, the typed report. If they take out this printout and then they type it out on a separate paper and give us, and in which half of the information is usually not given to us. So rather than that, if we start using this, the whole report in our clinical practice, that helps us immensely. So for all the trainees, it's always EDTA that we are using as an anticoagulation, and it's necessary to analyze the report as early as possible. So don't keep samples overnight and analyze, because then a lot of variables become wrong as a result. And this is how a usual report comes out. This is a screenshot of the machine, that is the screen of the machine, where you have a red cell channel, a white cell channel, and a platelet channel. And new automated analyzers have many more channels like a reticulocyte channel, etc. added to it. So if you can see, the red cell channel is giving us what information? It gives us hemoglobin, it gives us RBC count and MCV, which are all directly measured by the machine. And the rest of the markers like a hematocrit, MCH, MCHC, and RDW, these are all calculated variables by the machine. So this is the red cell channel, and in association with this, there is a scatter plot here, a histogram, which is telling you the distribution of red blood cells. This is something which we don't otherwise get, but if you ask them, they can send it to us. And this also gives us more information. So this is against the size of the RBC. So as we know, the MCV is actually telling us an average of the sizes. So even if there are some outliers like small RBCs and large RBCs, and the average is going to come as normal. So even if this is normal, at times you may look at this histogram can give us more information. Similarly, WBC count this is a 5-part differential. Some machines give us a 3-part differential. So again, this is the complexity of the cell, which is mentioned. This is a laser technology which is used here. And the platelet, again, platelet count and the mean platelet volume is given here. Mean platelet volume, again, exactly similar. It is an average. But one look at the histogram tells us that there are some large platelets in the circulation. So even if your count is coming as normal, you know that there may be some large cells which are not actually counted by the machine. So platelet count might be higher than this. So we'll start with the red cell series. So red cell series, we all know, we have learned all this. But then when we are taught during training, we really don't know how this can be used in clinical practice daily. So we look at hemoglobin, you know whether the patient has anemia or not. Then the other information, most vital information which is coming from the red cell parameter is the MCV. The MCV is essentially the size of the red cell, and MCH is the degree of hemoglobinization, the hemoglobin inside and all the RBCs together, and MCHC is hemoglobin inside one RBC. MCH and MCHC are not too useful in clinical practice to us, but MCV definitely has to be looked into immediately after hemoglobin. Next thing what we look at is MCV. Again, when we are used to getting reports from other outside labs, they usually give us the normal ranges which are normal for adult population. They're not going to give us age appropriate ranges. So if you're working in pediatric departments, we could ask our pathologists to start giving us age appropriate. So Nathanowski is a hematology textbook which has all age appropriate ranges, and there are some Indian references also available. If you don't have that, then the best way is to look at, there are age-based calculations available. So the lower limit of MCV would be 70 plus age in years for most of the pediatric age group. So for a 2-year-old child, an MCV of 74 is actually normal. Although the report is going to give you, the machine is going to flag it, but if you calculate based on the formula, it is going to be normal. Similarly, upper limit is beyond 1 year, it would be 0.6 into age plus 84. This again, simple reckoners which can be kept at in your clinic, where you can really look at and immediately say whether this is high or low. And also, since MCV is a range, so MCV is an average, you are not actually getting the entire range. So sometimes histogram, looking at the histogram. So here you can easily see there is a dual population of cells. This usually happens once you have transfused a patient. So there is probably this population of larger MCV was the original population, and the patient has been transfused with normal red cells, and that is why this hump has come up. So this information says thalassemia also, you get dual population if you have received transfusion. And sometimes in combined nutritional anemias, where there is both iron deficiency and megaloblastic anemia combined, this kind of picture would come. But here, all these conditions, MCV would come as normal. So that is why looking at histogram is going to help us. There is this MCHC. If it is high, it is helpful in conditions where there is cellular dehydration. So the small cells with hyperchromia, it helps in hereditary spherocytosis. It helps in some sickle cell disease. But other than that, it's not of much help. It all helps the pathologist to tell whether the machine is working properly. So it acts as a quality control for them. So based on MCV, we can classify as microcytic, normocytic, and macrocytic. Microcytic for our usual clinical practice, it would be iron deficiency or beta thalassemia trait. And once in a while, if you have a chronic disease which has gone on for a long time, then they come with microcytic hypochromic. And normocytic would be essentially something to do with the marrow. So it would be marrow failure or marrow infiltration, and sometimes destruction happening outside, like a hypersplenism, enzyme deficiencies, etc. And macrocytic essentially for most of the clinical practice is B12 or folic acid deficiency. But we should remember a couple of things here, that all macrocytic anemias are not megaloblastic. So megaloblastic means there is a change which is happening in the bone marrow in the RBC production series. That is not here. So that is not seen in normal newborn. Normal newborn have macrocytic red cells. That is not seen in hypothyroidism, Down syndrome, liver disease, etc., where the red cell membrane is abnormal. So because of which there are macrocytic red cells. And once in a while, even marrow failure like Fanconi anemia, your congenital marrow failures will also have high MCV. So this is the MCV based classification, again, very simple to use in practice. What we must know as clinicians is that MCV always may not be correct. Like very high MCV, if you say getting 125 or 130 MCV, that does not mean that it is macrocytic or megaloblastic. It is usually artifactual. If you have kept the sample for a long time, then MCV increases. If there is biochemical issues, like if there are biochemical problems like hypoglycemia, hypernatremia, then also MCV increases. And again, another not so uncommon condition in clinical practice is red cell agglutination as an autoimmune hemolytic anemia. Many children who have a fever followed by sudden fall in hemoglobin, red cells are agglutinating in room temperature. The machine does not know this agglutination. It's going to calculate this entire clump of red cells as one cell. And that is why the MCV comes fallaciously high. So whenever that happens, the pathologist can easily look at it. Now the third information, after hemoglobin, MCV, then comes red cell distribution width. Again, a very simple concept, but it can be of immense help to us in clinical practice. So this is how normal red cells are. They're all produced in a similar size and shape. But if you have anisocytosis in the system, because of, say, you have here probably there is iron deficiency. So there are small cells, very small cells, and there are normal cells, because of which the distance between individual RBC is changing. So if you take an average of the distance between RBCs, in a normal person, it would fall like this. It will be in a narrow range. Whereas if it is in an anisocytosis, due to whatever cause, usually nutritional anemias have anisocytosis because all cells are not produced similarly. So you have mild IDA, then RBCs will look deficiency, then RBCs will look like this. So then the distance between the cells is going to be different. And as a result, the RDW increases. And machines report it either as standard deviation or coefficient of variance. So either way, it will give you a report. And that also helps us in clinical practice. If your RDW is raised, then usually you consider nutritional anemia. So now hemoglobin, MCV, and RDW, you have a better now. So all this again from the single Coulter report that we have with us. So if your MCV is low, we know it is beta thal. Usually we thought it was beta thal and iron deficiency. But if RDW is high, then you have all the more reason to consider iron deficiency. If MCV is normal, we thought of marrow failures, etc. But if MCV is normal but RDW is high, then you know that this MCV is fallaciously normal. It's actually a mixed deficiency what is there in the system. And if MCV is high, we thought of aplastic anemias, and as in we thought of folate and B12 deficiency, which where RDW will be high. And aplastic anemias also, some of them like Fanconi can have MCV high. You can differentiate that based on the RDW. Now, again, some thumb rules in clinical practices. One, we all know that hemoglobin into 3 is hematocrit. That we already know. So hemoglobin is, say, if it is 15, you expect a hematocrit of 45. But there is one more calculation. RBC count into 3 will give you hemoglobin. So if you have a hemoglobin of 15, you're expecting an RBC count of 5. So if I'm getting a patient with a hemoglobin of 10, I'm expecting an RBC count of around 3.5. So if you have a report like this, so this child is probably a 6-year-old boy who's been brought with mild anemia, or maybe this is done for some other condition and you get this report. So there is mild anemia. There is a MCV of 59.6. So logically, it should be a iron deficiency as the first differential. But see the RDW is in the normal range. So you think twice before you consider iron deficiency. And the third information you can get from this is the RBC count. For a 10 hemoglobin, I was expecting an RDW of 3.5. Here the RBC count is 5 instead. So that means there are more red cells produced for the degree of anemia. So that means there is no production defect as such. The hemoglobin the RBCs are being produced out of the marrow normally, but the globinization is wrong in that. So this is actually a beta thalassemia trait. So this is a very easy. We know of many calculations which we do Menser index, Shine and Lal index. There are many indices to calculate beta thalassemia trait, as in differentiate iron deficiency from beta thalassemia trait. But you don't really need all this. Just this thumb rule of into 3 can help us differentiate. So if it is proportionately low, then it is iron deficiency. If it is not proportionately low, it is much higher than what you expect, then it is beta thalassemia trait. So here again, this is an iron deficiency anemia where there is hypochromia. There are different sizes of cells, anisocytosis because of RDW, and because of which RDW will go up. And third is RBC count will be proportionate to the degree of anemia. Whereas here, this is a beta thal trait. All cells are produced. The factory is perfectly working normally. All RBCs are produced normally, but because of the globinization defect, they are small and they are hypochromic. And that is what you are seeing in the Coulter report also. Now coming to the reticulocyte part. The reticulocyte also can be calculated now in a Coulter. So there are automated Coulter reports which we give there. Otherwise, it can be done by the pathologist using what is called supravital staining. Again, it should be done immediately. 3 things which are helpful. One is absolute reticulocyte count. We calculate absolute reticulocyte count as a percentage of your RBC count. Second is a corrected reticulocyte. We really need to know whether the reticulocyte count you've got, like say 2% or a hemoglobin of say 5, then you need to know whether that is actually correct. Because for that hemoglobin of 5, you are not expecting a retic of 2% means that the marrow is working normally. So for that, you correct it for the actual hemoglobin or actual hemoglobin divided by expected hemoglobin, or actual PCV divided by expected PCV. And that's a simple calculation. So if it's 5 and you are expecting 15, it will be 5 divided 15, 1 by 3 into actual retic count will be 2 divided by 3. That will be around 0.8 or 0.7. So that would be, but that would tell you that the marrow is not working normally. So that correction has to be done for all anemias. And to take it one step further, you can actually correct for the time of the time that the reticulocyte spends in the circulation. This is again given in Nelson. So that also tells us whether there is hypoproliferation or not. And this is especially helpful in our normocytic series, where if you get RPI of less than 2%, it's hypoproliferative, where if it's more than 2%, then you look at hyperproliferative marrow, like in hemorrhage or hemolytic anemias. But if it is less than 2%, you know something is wrong with the marrow. Bone marrow has to be done immediately. Coming to the WBC series, you have automated differential. It's the technology is very good nowadays to help us differentiate all these cells. It's almost like flow cytometry for leukemias. You get it very well. And you have a 5-part or a 3-part differential that comes out. But if you look at a close, so these are 2 reports which have come out. Hemoglobin is the same. So 3.19, here it is 3.09. But if you can see the rest of it, here the degree of neutropenia is more. Here, the degree of thrombocytopenia is very severe. And if you look at the MCV, it is not very high. So this child, I would prefer that the marrow is definitely done in this patient after transfusion, so that we're giving sedation. And because this would look for me, this would be either aplastic or leukemia, very surely. But if you look at this one, if for the same hemoglobin, your MCV is quite high. So if this is high, platelet is not, it's in a moderate thrombocytopenia. Again, neutrophils are low, but not low. I would go ahead with a peripheral smear here. If there are hypersegmented neutrophils and other features of megaloblastic, would just give a treatment trial with and look for response rather than doing bone marrow at the first go. And the third part would be platelets. Platelet, again, the platelet distribution width gives you a lot of information. So if this is a normal one where there are some large cells in the circulation, and these large cells are actually informative for us in thrombocytopenic states. And also we have to look at where the graph is starting. So if you're starting at a higher cells, it means there are extremely small platelets in the circulation. Or if your platelet histogram is going on like this, that means there are very large platelets in the circulation. And this again gives us information for the same platelet count. So see, there is a child with a platelet count reported by the machine as 82,000. But if you look at the histogram, you can easily see that there are large platelets in the circulation. And when you ask for a manual, it's coming back as 1 lakh. So always in thrombocytopenic, always rely on a manual platelet count. If you do not have access to that, look at the platelet histogram. That gives us more information. And many a times the machine actually is counting the platelet based on the size of the platelet. So if you have clumps of platelet in circulation, if your platelets around a neutrophil, which is called platelet satellitism, these conditions very common in pediatric practice, or if there are fibrin meshes inside the sample, if you're taking sample if you're breaking the hub and just taking with the needle, many a times coagulation would start even inside the vacutainer. And because of the fibrin thread inside the vacutainer, all the platelets will get clumped onto it. So the Coulter is not going to give you a wrong report. So beware of pseudothrombocytopenia in these scenarios. The other information which comes from the platelet is a mean platelet volume. This is a normal platelet volume. This is exactly like a mean corpuscular volume for red cells. And if you have a high mean platelet volume, that means there are younger platelets in the circulation, and that helps us again get information. So if you have a 35,000 platelet count with a high MPV, you know that the marrow is producing normally, but there is peripheral destruction, as you would see in ITP. And this again, this information is helpful for dengue as well. You know that if MPV is high, then you know that good platelets are there, and they are going to rise in the next few days. Where if you have small platelets, MPV is normal to low, then you know it is marrow suppression. Or if it's very small platelet, young boy being brought with thrombocytopenia with MPV less than 7, then you should consider Wiskott-Aldrich as well. The new machines have some more information, like you can have reticulocyte count, also reticulocyte what is called immature reticulocyte fraction, which can be got from these cells. And many in the next few years, these reports are going to come to us regularly. That helps us know that the marrow is regenerating. We can avoid a bone marrow if it's like a sepsis-induced marrow suppression. If you have IRF coming up, then you know that marrow is going to regenerate in the next couple of days. Also, reticulocyte hemoglobin tells you it's a very, very good marker for early iron deficiency. So rather than relying, it's better than biochemical parameters like iron or ferritin, which has a lot of fallacies. Another thing is fragmented red cell in patients with sepsis or patients who have sepsis, DIC, HUS, TTP, those kind of conditions, there would be red cell fragments in the circulation, and that can be taken. In fact, a lot of nephrologists now rely on fragmented red cell count for patients who are being followed up for these diseases. Then another one is immature granulocyte fraction, again coming up here. This is available as on a research mode in most machines, and that can easily tell us it's a very good indicator of sepsis and infections. And I think in neonatology practice, this is coming up in a big way. And another thing is malaria parasite. Now many machines can actually tell you the red cells which are infected with the malarial parasite. So again, in one go, a fever investigation, even a CBC report can actually tell you the diagnosis of the condition rather than relying on one more investigation. And another thing, like I mentioned, IRF, that is immature reticulocyte fraction. There's something called immature platelet fraction that is coming up, and that has been studied immensely now. So every dengue season, even there are labs here which are giving out immature platelet fraction as a report, and that can again avoid unnecessary anxiety. So if your platelet is 7,000, but your immature platelet fraction is going up, that means you are expecting a platelet recovery in dengue in the next 2 to 3 days. So this kind of information can avoid unnecessary transfusions, anxiety, because a lot of usually platelet counts less than 10,000 is associated with panic, both for the clinician as well as for the patient family. So whenever we have a CBC report, look at whether it is single line, bicytopenia or pancytopenia. If it is single line, if it is just a low hemoglobin, look at the MCV, look at the RBC histogram. In majority of conditions, you can get to a diagnosis here. If you have low platelets, check the MPV and the platelet histogram. And low platelets, better to get a manual platelet count done by your pathology colleague. If you're bi or pancytopenia, first look at the differentials. The differential, if it is lymphocyte predominant, then you need to know that the marrow, there is something seriously wrong with the marrow. MCV can help us in avoiding marrow in some conditions like megaloblastic anemia. It can help you avoid. If you have a very classical picture and your smear is suggestive, you may not need any further investigation. And degree of thrombocytopenia also helps. Platelet count of less than 10,000 or less than 5,000, it is never nutritional. It has to be a marrow failure syndrome. And again, that helps us differentiate condition. And in smear, always ask for all thrombocytopenias, all pancytopenias, ask for a peripheral smear. And low hemoglobin, but normocytic or macrocytic, that is usually not nutritional. And in these conditions also ask for a peripheral smear. I have 2-3 cases. I'll just quickly go through it. So this is a 7-month-old child with pallor since 15 days who has come with nothing else other than hepatosplenomegaly. So 7-month severe pallor, hepatosplenomegaly. For me, the first differential would be beta thalassemia in this population at least. So you look at the hemoglobin, it is 2.5 and the MCV is low, 62 femtoliters, which is low. So it is microcytic population predominantly. And 7 months, usually iron deficiency does not come with this degree of pallor, this degree of anemia at 7 months of age. So again, it is corroborating with nutritional anemia. Now, thalassemia. Now, the next thing what I want to look at is the WBC count. So the I would have expected a normal WBC count in this child, but here it is 41,000. So 41,000 lymphocyte predominant. Again, my antenna is up as to maybe there is something else happening. And look at the platelet count. Platelet is also low. So as a second differential and the third differential, I'm going to put bone marrow infiltration also as a condition. But still, since this kind of picture is coming in leukemia and storage, I would have expected a normocytic picture here, but that is still not there again. So I'm going to still put THAL as a first differential. What happens in the peripheral smear? It is classical of hemoglobinopathy. You have all these different types of cells, anisocytosis, some broken cells, very classical. And what is more classical is the nucleated red cell, which has come in. See, and these nucleated red cells, the machine does not know that it is a red cell because there is a nucleus. The machine is calculating it is in the WBC channel. And that is why we have a high white cell count here. So that needs to be corrected for the degree of NRBCs in the circulation, and that the pathology, again, they would tell you that this is the corrected WBC count, and that is why that fallacy was happening. And what was the third problem here? That the platelets were low. Many a times when you are diagnosing thalassemia also, there is some degree of hypersplenism which would have set in already, and that is why this is happening. And this actually reverses very quickly. Once you transfuse 1 or 2 times, the platelet counts improve in this scenario. So we went ahead, we actually, this was a referred patient. The patient had a transfusion already done. So because of which the HPLC is not giving us much information. So we go ahead with the parental HPLC. This is the father's HPLC, HbA2 is 5.5. This is the mother. This is again 5.2. But let us look at the rule of thumb here, whether it's working. It is. So hemoglobin was 11.1 for an adult male. That was anemia. Look at his RBC count. It is 6. For a 6 RBC count, my hemoglobin should have been 18. But here it is only 11. So the red cell RBC count is much higher than what you expect for the degree of anemia. And indices are also suggested. So a very one glance will tell you that even without the HPLC will tell you that this is the thalassemia indices that you are getting. Another child, 11-year-old boy, growth is on the 10th centile, who has come in with fever and pallor since 2-3 months. If you look at him, he is little hyperpigmented, little abnormal facies is there. Look at the hemoglobin, it's 3, and MCV is slightly on the higher side, 99, and MCH, MCHC okay. WBC count low, ANC very low, platelet count also low. So this pancytopenia with a mildly raised MCV, first differential is aplastic anemia, considering the growth as well as considering monitoring the facies also. Maybe this is Fanconi, and corrected retic helps us a lot in this condition, which is 0.1. The closest differential to this is a megaloblastic anemia, because MCV is still high. This could still be megaloblastic, because we do see ANCs like this and platelet like this in megaloblastic also. But in those conditions, your corrected retic should have been in the 0.7, 0.8 range, not 0.1. Here, this means that the marrow is completely not functioning, and a smear proves it, and a bone marrow also proves it, that this is completely an aplastic marrow. And another case, 5-year-old girl, a short duration fever with pallor. She's come with a pallor and mild icterus and a cervical lymph node. If you look at the hemoglobin 3, MCV is quite remarkable, 104. So again, first differentials are that this could be megaloblastic. TLC is okay, not so low, platelet mildly low. So again, bicytopenia essentially with high MCV, first differential is megaloblastic, but you can't be too sure, especially with lymph node there, and then you go ahead and do a marrow for that. Corrected retic you see here, very low, it's 0.6, and bilirubin also, because there is destruction happening in the marrow also, there is unconjugated hyperbil, and that again proves us that this is megaloblastic. And the last case I want to show is a boy with a 3-month-old boy with a massive abdominal distension, transfused once, growth failing to thrive, massive splenomegaly. Look at the hemoglobin, it's 5. Indices are normal. So as indices means MCV, MCH, MCHC not abnormal at all. TLC is okay. Platelets are mildly low. So this is some kind of hypersplenism with bicytopenia which has come up. Since indices are okay, the first differential would be actually marrow infiltration with Gaucher or some kind of storage disorder. THAL, unlikely. Non-transfusion dependent THAL can come like this, but then MCV should have been low. Portal hypertension, again, if this is bleeding, then it should have been, that should have caused iron deficiency, and MCV should have been low. So that is how you, even with a CBC, you can come to a lot of conclusions. Smear shows some monocytosis, marrow shows all the classical storage cells, and it was molecularly proven also. So I'd just like to conclude that if we in clinical practice, if we go beyond that usual hemoglobin TLC, DLC and familiarize ourselves with histograms and red cell indices, it gives us a lot of information. Correlate with smears, start talking to our pathology colleagues, that helps us a lot, and look for trends in response as well. That also helps us a lot. And thank you very much, and I will be happy to take questions.
Thank you. Thank you, Nita. So I think short of time, we will directly go to 1 or 2 questions are there. One thing is, which you have not touched upon, role of neutrophil lymphocyte ratio in various infectious diseases. I think it's a very elaborate question, but you can small in a short way.
Yeah, so I had a whole set of slides on COVID. I thought I'll remove it because of lack of time. So NLR ratios are helping us in many infections, especially COVID now. So COVID also has a very typical pattern of CBC. So even when the PCRs are not positive, we just one look at the CBC will tell you that this is COVID. So COVID, hemoglobin series, nothing really happens. WBC, what happens is the first 1 or 2 days of fever, neutrophils really go up, and lymphopenia is very remarkable. So that helps us. Then platelets also start dropping. So that helps us in this. And this pattern of COVID, first 2 weeks later, this pattern also is reversing. There are some abnormal lymphocytes which start coming up, and that lymphocytes have a very particular pattern of presentation. And some pathologists have started calling it covicytes also. I don't know if it is valid, but that pattern is very helpful. And the NLR has been correlated to severity of clinical presentation, stays, need for all additional medicines in COVID, like remdesivir, etc. And there are some correlations which have come up in that also. So it is helpful in practice.
Okay. And one more question, is it possible to differentiate hereditary spherocytosis and autoimmune hemolytic anemia with CBC and peripheral smear alone if DCT is not available in their setup?
See, autoimmune hemolytic anemia, if it is warm autoimmune hemolytic anemia, it is going to show us spherocytes. And the hereditary spherocytosis also gives us spherocytes. You go ahead and do osmotic fragility, it will just tell you that those small cells are fragile. It will break in both the conditions, osmotic fragility will be high. So the only thing which actually helps you is the history. So if you have a family history, if they say spherocytosis is a dominant history usually. So dominant history, one of the parents have a spleen or one of the parents have similar mild anemia with spherocytes, that will help us a lotly. AIHA is usually short history, no family history at all. That helps us in clinical practice. And the second is, of course, DCT.
One more question was there, which already you have explained. They want some clarification. Due to lack of time, we are not taking it. I think already 10:15. Madam, thank you, Nita, for an excellent talk and excellent deliberations and discussions. Thank you. Over to you, madam.
Thank you. Thank you, Nita, for that wonderful presentation. And thank you, Shankar, for the excellent way of sharing it. So thank you for the interaction also. Now, I think we'll straight away go for the inaugural function. A short inaugural function. Thank you, everyone. So I'm just myself, I'm going to give the welcome address. So distinguished chief guests of the day, Dr. Remesh Kumar, I don't know whether he has joined, I can't see. National.
Ramesh Kumar sir is here, madam.
Okay, right. Ramesh Kumar, the president-elect 2021 and 2022, and the president of Kerala State IAP, Dr. Jayaraman, secretary, Dr. Johnny Sebastian, and then our own Trivandrum district branch IAP president, Dr. Santhosh, Dr. Riaz, he is the CIP executive EB member, and then Praveen, secretary of the Trivandrum IAP district branch, all the other distinguished faculty members, especially I can see Dr. Jagadish Chinnappa, Dr. Kashi, and all the other senior persons, and all our chairpersons, including Dr. T.U. Sukumaran. A very good morning to one and all. It's a pleasant privilege for me to welcome you all to this 7th annual CME of the Pediatric CME of the Gokulam Medical College, jointly organized by the Department of Pediatrics, Gokulam, as well as the Trivandrum IAP district branch. And this time also, because of continuing COVID pandemic, we have been forced to conduct this on a digital platform. But being in a digital platform has its advantages as well, because it's being a digital platform, I could bring all the excellent faculties, that is who is who in pediatrics, to this CME. So that way I'm extremely happy. And they're all going to share their expertise with us, especially in dealing with the common scenarios that which we pediatricians see in like everyday practice, like as Dr. Nita has discussed, how to interpret CBC. Now going to see what are the common drugs that we can do in the respiratory therapeutics, and like what is new in vaccinology, etc. But the only thing we are lacking is the joy and the warmth of the physical togetherness. But I think how we have now learned to live with this new way of normal, and I think we expect that for longer than we anticipated. Now, moving on to the pleasant duty of welcoming the chief guest of the day. We are really fortunate to have Dr. Remesh Kumar, the president-elect IAP 2021, with us here to inaugurate the function. And as all of us know, he's such a dynamic and energetic person, a man of action with strong devotion and commitment to the betterment of the child health in the national level. And he had made us all proud, the Kerala IAPians, especially by getting elected to the coveted post of the national president. I'm extremely happy to welcome you, Dr. Remesh, to do this inaugural function, as well as wish you all the very best for the activities or tenure as the IAP national president. And then we have our president, Dr. Jayaraman, state IAP president, as the for his address, a soft-spoken, at the same time a gentle person, but with the strong commitment, with a lot of action plans for the betterment of the health of children of the IAP Kerala state. A very hearty welcome to you, Dr. Jayaraman. Then we have Secretary Dr. Johnny Sebastian of the IAP Kerala state also with us. Along with Dr. Jayaraman, he is also very active in implementing all our state action plans for the coming year. And very warm welcome to you, Dr. Johnny. Then we have Dr. Santhosh, who is the president of our Trivandrum district branch. He is also a multi-person HOD of the Department of Pediatrics and the superintendent as well as of the SAT hospital and the nodal office. But in spite of that, though he could not attend the function, he has agreed to he has come out with a video message for this inaugural function. Now I have Dr. Riaz, the central IAP EB member, my own student, now has colleague, and my now in addition to the advisor to the state IAP president, he has become advisor to me also in the organization of all these activities. A very warm welcome to you, Dr. Riaz. Then we have Dr. Praveen, the Trivandrum IAP district secretary, aptly called as the tech person of IAP or the IT person of our Trivandrum district branch. He is also extremely helpful to me and supportive in all the academic activities, especially organizing this event. A very warm welcome to you, Dr. Praveen. In addition, as I mentioned, I'm very happy to welcome all our distinguished faculty members, as well as the chairperson to this function. And more than that, I'm extremely happy to welcome all the senior pediatric colleagues, as well as the HODs of the various departments, as well as all the residents and all the pediatricians who have joined in this webinar. A very warm welcome. I'm extremely sure, I hope that this academic feast that is being planned by us is really going to be useful for you, and then you will become definitely wiser at the end of this session. And a very warm welcome to one and all. Thank you. Now with this, may I invite our chief guest of the day, Dr. Ramesh Kumar, the President-elect National President-elect 2021-2022 for officially inaugurating the CME as well as his address. Over to you, Dr. Ramesh.
Respected President of the Academy of Pediatrics, Trivandrum branch, Dr. Santhosh Kumar in absentia. President of IAP Kerala State, Dr. Jayaraman. Organizing chairperson, principal of the first branch, as well as the institution, our own Madam Dr.Lalitha Kailas, HOD of Pediatrics, Dr. Gopinathan, the organizing secretary, Dr. Shaji, secretary of the Trivandrum branch, my dear friend, Dr. Praveen. We ask the honorary, the National Executive Board member and the most beloved friend from Trivandrum, my teacher and mentor, Dr. T.U. Sukumaran sir, State Secretary, Dr. Johnny, Dr. Sankar, and other senior leaders from Trivandrum, the esteemed faculties that I can have right now, Dr. Kashi, Dr. Jinappa, and others in the platform, and dignitaries of Indian Academy of Pediatrics and fellow friends from the Academy. Very good morning and greetings of the day. Greetings for Palm Sunday, in fact, where our Christian brothers are celebrating, or of course, observing the Palm Sunday today. And across the country, it's a holy festival catching up. I'm really fortunate and privileged as well as humbled to be there with you in this platform with my seniors, my professors, in fact, Sukumaran sir, Lalitha madam, where I am really humbled to be the chief guest, in fact. And I will seen just now it's the 7th CME, and every year I wanted to be there with the Gokulam Medical CME. Lalitha ma'am knows about it. Somehow or other, the family benefit scheme meeting, March 3rd Sunday, some or other important IAP function activities will be there. And most of the time it was FPS meeting, 3 occasions. I just missed it, and now it's the last 2 years, it's the COVID. But always it's really very attractive scientific CME organized by Gokulam Medical College. And Trivandrum IAP has got numerous achievements to study, and being one of the numero branch in IAP Kerala, as well as best branch in the national level also this year. We've got a lot of vibrant activities coming up. And the branch, in relation with Gokulam Medical College, is sure to deliver a wonderful CME out here. Of course, with medical colleges, always it brings up fostering better scientific knowledge and better of academic excellence. And that here too, today this CME has attracted faculty from, green faculty from across the country. And as ma'am has put it, because of the virtual platform, we are able to corner the who's who in practical pediatrics across the country. And the topics also, of course, mostly thought-provoking as well as unique topics. And I'm sure our faculty out here should be really enriched of members who are joined here with their unique insights into these subjects. And no wonder we have got such a good participation considering the webinar pandemic, which a lot of webinars going on. And today itself, we have got around 8 or 10 webinars which have come today. But we have got quite a good participation. That itself signifies how catchy are the topics here and how important is the Gokulam CME for the pediatricians of this part of the country. And at IAP Kerala also, we are having a lot of initiatives. President Dr. Jayaraman and Dr. Johnny are out there continuing the momentum built up by Dr. Narayan and Bala last year. At Central IAP again, we have got a lot of newer initiatives from the President Dr. Piyush Gupta. We have got the parental guidelines and we have got the early childhood development platform plan coming up. We can continue all these activities at the state level, at the national level, the year to come. And I honestly solicit all your support and blessings in continuing the great academic momentum which has been built up in the state as well as at the national level in the year 2022. And I believe my friends here, I can see the guidance of Sukumaran sir, Lalitha ma'am, Jayaraman sir and others, and Dr. Riyas, my dear friends, Shankar and all others around. We can really contribute in a big way to the scientifics for the year coming and other activities. Friends, with all humility as well as pleasure, I happy to declare this CME as open, and I wish the scientific deliberations are going to make you wiser and empower the pediatric community here with better or equip them better to face the day-to-day challenges in office practice as well as in the institutional settings. I wish the conference all success, a great day of learning out here for all my friends. And once again, my sincere gratitude to the Gokulam Medical College, as well ma'am, Radha ma'am, as well as Shaji, Dr. Shaji, as well as Dr. Raghunathan, and as well as Trivandrum IAP for the opportunity to be here with you on this great day, and wishing you all a great day of learning. Thank you.
Thank you. Thank you, Dr. Ramesh, for that encouraging words, and thank you again. And may I invite now Dr. Jayaraman, the President of the State IAP Kerala, to address the gathering. Over to you, Jayaraman.
Good morning, everybody. Hope I'm audible. Respected Organizing Chairperson, Dr. Lalitha Kailas, President-elect of IAP, Dr. Ramesh, Dr. T.U. Sukumaran, past National President, Dr. Johnny, Sebastian, Secretary, Dr. Riyas, National EB Member, Dr. Praveen, Secretary of IAP Kerala, IAP Trivandrum, Dr. Sankar, faculties Dr. Jagdish Chinnappa, Dr. Kashi, and Dr. Shanavas, who is the convener of the faculty cell of IAP Kerala, all the other dignitaries on the platform. It gives me immense pleasure to address all of you on this occasion of the CME conducted by Gokulam Medical College Department of Pediatrics. Actually, the preparation gone in this CME is so much that this was the CME actually. Dr. Lalitha Madam called me even before I took over as the state president of IAP Kerala way back in December, and she told you have to block March 28th for our CME. So that is the amount of preparation she has done for this CME, and I congratulate you on the meticulous selection of the topics as well as the faculty for this CME, because and you have given so much stress to office practice in pediatrics rather than purely academic issues. That indicates that reflects the number of people who have joined for the CME, I believe. And I think I am audible.
Yes, sir.
Yes, yes.
Yes, sir. Yes, sir.
Yes, there are.
Yes.
Audible.
And
Audible.
you have done it in such a way that you have included almost a lot of practical issues which a pediatrician faces, and this will be marked as an important event in the academic calendar of IAP Kerala for the year. And I'm very happy that Gokulam Medical College Department is continuing its traditions for all the years. Thank you so much for giving me this opportunity to address all of you. And thank you once again for all the wishes, Dr. Remesh, for our activities. And we have rolled out almost all the major action plans by March. And we hope we will be able to continue the very best for the coming year. Thank you so much and wish you all the very best.
Thank you, Dr. Jayaraman. Now we have Dr. Santhosh Kumar to offer his felicitation, but I think he had informed that he is not in a position to attend, but he had instead sent a video address.
Respected teachers, colleagues, and friends, good morning. Thank you very much for inviting me to felicitate Gokulam CME, the 7th edition of Gokulam Pediatric CME. Lalitha Madam, we all know, is very meticulous in organization in addition to being astute clinician and academician. So that meticulous nature is reflected in each and every Gokulam Pedicon that has been organized so far. And the restrictions imposed by COVID actually is utilized for incorporating more national faculty of repute in this 7th edition of Gokulam Pedicon. And as usual, the topics selected are all most appropriate for pediatricians. And I wish all the very best for this conference, and also wish that this conference happens year after year. Thank you. JIAP.
Thank you, Santhosh, during his absence. Now may I invite Dr. Johnny Sebastian, Secretary of the IAP Kerala State, for his felicitation. Over to you, Johnny.
Good morning all. Respected Lalitha Kailas Madam, Organizing Chairperson, Gokulam Pedicon 2021. My mentor and chief guest of the day, Ramesh Kumar Sir, National President-elect CAAP. My leader and guide, Jayaraman Sir, President IAP Kerala. Professor Dr. T.U. Sugumaran Sir, past National President. Dr. Santhosh Kumar Sir, President IAP Trivandrum. Priya Sir, NEBM, CIAP. Esteemed speakers of the day like Dr. Jagdish Sir and Kashi Sir, seniors and my dear colleagues and friends on this platform. At the outset, let me congratulate the Department of Pediatrics, Sree Gokulam Medical College, for organizing this Pedicon today. In fact, it is the 7th annual CME program organized today. I was fortunate to attend most of them, traveling all the way from Kannur because of the quality of the CME is always assured. And as usual, even today, the topics and speakers are meticulously selected. I'm sure that all the participants are going to have a great academic feast today. I wish this CME all success. Jai Hind, Jai IAP. Thank you.
Thank you, Dr. Johnny, for that nice words. Now, may I invite Dr. Riaz, EB member, my own colleague, the vibrant advisor to the state IAP president, for his felicitation. Riaz.
Thank you, Madam. Respected chair of the meeting, Lalitha Madam, and chief guest Ramesh Kumar Sir, President IAP Kerala, Jayaraman Sir, my dear friend Dr. Johnny, and all the respected faculties and chairpersons, as well as my dear friends. It is with immense pleasure that I join every time with Lalitha Madam's meeting. I have never missed a meeting over the last 7 years, and she make it a point to include me in some way or other. And actually, we know that today the attendance for the first session itself was nearing 200. This is the only thing which we need to know about the Gokulam CME, which is in its 7th year. And every year she chooses topics which is useful to both practitioners as well as postgraduates. The talk which just now occurred, Dr. Nita's talk, I think if any PG had missed it, it will be a great miss, because we never analyze the graphs which we get along with the peripheral smear so well. I think we should share the recording with the IAP platform after the meeting. I offer all the very best for the meeting, and I wish the Gokulam CME happens every year without any break. Thank you, madam. Thank you, everyone. All the best.
Thank you, Riaz, for that really encouraging words. Now, with this, move on to the end of the session. I invite Dr. Praveen, Secretary of the Trivandrum IAP District Branch, to offer the vote of thanks. Praveen, please.
Thank you, madam. It's indeed a privilege to be part of this great academic program organized by Lalitha madam and team. As already told, with a great participation nearing 200, we know that due to the selection of topics and the speakers, this happens every year. And on behalf of IAP Thiruvananthapuram branch and the Department of Pediatrics Gokulam, I extend a hearty vote of thanks to all the speakers, panelists, and all the attendees for gracing this occasion. A big thank you to our dear Ramesh Kumar sir for the inaugural address. Then a big thank you also to Dr. Jayaraman sir, President IAP Kerala, then Dr. Johnny, Sebastian, Secretary IAP Kerala, and Lalitha madam and her team actually request a big applaud for this organizing this great meeting. I also extend a big vote of thanks to all the other attendees, all the panelists and the speakers. Thank you, madam.
Thank you, Ramesh. Thank you, Praveen. So now we have come to the end of the inaugural section, and without wasting much time, I think let us move on to the next scientific program. So the next session in the scientific program is the lecture by Dr. Jagadish Chinnappa. He is going to talk us on unresolved issues in pediatric respiratory therapeutics. I'm sure that is going to be a really interesting and an exciting session by such a renowned person in the pediatric pulmonology. And to chair the session, we have Dr. T.U. Sukumaran. A very warm welcome to you, Dr. Sukumaran. Just to introduce, I don't think this crowd needs any introduction of Dr. Sukumaran. He's the retired professor and HOD from Government Medical College, Kottayam. And then he had joined Pushpagiri, and now he's the pediatric consultant and HOD of the Pediatrics of Kailas Hospital. And more than that, he was the National IAP President 2011 and very active in the pediatric pulmonology chapter as well as the pediatric environmental allergy chapter. A very hearty welcome to you, Sukumaran, and thank you for accepting my invitation to chair the session. Now, over to you to introduce the speaker as well as the topic. Over to you, Dr. Sukumaran.
Beloved chairperson of this conference, my beloved friend, Dr. Lalitha Kailas, the President-elect of Indian Academy of Pediatrics, my beloved friend and student, Dr. Remesh Kumar, other dignitaries on the platform, and my dear friends. It gives me great pleasure and privilege to be here with you to participate in this Gokulam CME. I congratulate Dr. Lalitha and all the faculty members of Gokulam Medical College for organizing this wonderful CME program. And also I thank Lalitha for giving this opportunity to chair this session, especially to chair a session. And the speaker is a very close friend of mine, Dr. Jagadish. And Dr. Jagadish needs no introduction to you. And he was the past Secretary of Respiratory Chapter of India Indian Pediatrics way back in 2000. I still remember the first talk of Dr. Jagadish at Kottayam when we conducted a national seminar on bronchial asthma way back in 2000 when he talked on parent education for asthmatics. And also at present, he is the chairperson of the respiratory chapter. And I came to know that he is stepping down by 12:30 at Bangalore. There's a meeting is there. And Dr. Subbu is taking over as the chairperson. He's an excellent speaker, excellent orator. And also he is very much interested in pediatric pulmonology and immunization. And also I think there's a talk by him by 5 o'clock in Chennai also on immunization. He's an excellent speaker, orator, and a leader. And he was the national commissioner, election commissioner of Indian Academy of Pediatrics. And also at present, he is working as the chief consultant in pediatrics in Manipal Hospital. And he's going to talk on unresolved issues in pediatric respiratory therapeutics. As you all know, there are a lot of unresolved problems in the treatment of pediatric respiratory problems. For example, if you take the case of bronchial asthma, it's the commonest problem that we face. There is no much correct guidelines on how to manage long-term management of under 5 weeks or whether to give a long-term steroids or montelukast. And also, when a child with a persistent asthma is coming from acute episode, now the GINA guidelines 2020 say that you must give a combination of SABA, short-acting beta-2 agonist with inhaled corticosteroid. Previously, also years back, there was a combination of these two drugs was there. A combination of beclomethasone and salbutamol was there, but we were not encouraging that. At that time, we thought it was irrational to have a combination like that. Now the GINA is again saying that you must combine these two. And also for management of asthma in older children, you must use a combination of formoterol with budesonide. A smart therapy is there. So there are a lot of controversies there. Let's follow all these things. We don't know exactly. So to talk on these unresolved problems, we have Dr. Jagadish with us. With great pleasure, I welcome Dr. Jagadish, and I invite Dr. Jagadish to start his talk on unresolved issues in pediatric respiratory therapeutics. Dr. Jagadish, please.
Thank you, Dr. Sukumaran, for that really wonderful introduction to me and to the topic. Thank you, Dr. Lalitha, for bringing up such a topic, because usually when we are in pulmonology, we keep getting topics like, otitis media, sinusitis, asthma, but nobody comes up with this kind of a topic of unresolved issues, which made me really think about what are the unresolved issues. Thank you for inviting me, Dr. Ramesh Kumar, Dr. Jayaraman, Dr. Johnny, and Dr. Santhosh and Dr. Riaz, and all the other faculty and chairpersons. What I'm going to do in the next 20-25 minutes is to look at what are our problems. See, we have a large number of pediatric respiratory conditions. There are varied possibilities of therapeutics. Resolution means that you have achieved optimal therapeutic endpoints across all age groups, populations, and circumstances. Most therapeutics are in various stages of evolution. As Dr. Sukumaran mentioned, we have not reached anywhere. We are in a process of evolution and hardly have reached ideal set points of evidences to attain these endpoints. So let's consider how we grade evidence for some common respiratory problems. The basic thing is we rely on three things: medical decision making, research evidence, and clinical expertise. And as you know, all EBM, evidence-based medicine, is on the same kind of format of defining a problem, looking at an intervention, doing comparisons, and looking at the outcomes, or the PICO model. So, but we have to define the problem first. Now, looking at evidence, we have various levels of evidence, starting from expert opinion, which is of no use at all, and finally going on to systemic reviews, which is the best possible evidence. And let me tell you that for every problem that we have in pulmonology, we have very few RCTs and even fewer systematic reviews to give us really class A evidence of a recommendation. So I think that what is happening right now is, for a wide variety of respiratory problems, we have to deal with very incomplete evidence, and we have to mangle our way right through. Now this is a very nice cartoon which says the mother tells the baby, "Let me kiss it to make it better," and somebody says, "Don't listen to that lady because it's no better than a placebo." So evidence-based medicine is almost like that. So what I'm going to do is to look at 6 conditions which we commonly treat, look at what is the evidence base we have for each of these conditions, and see where our gaps are. First of all, let's start with my favorite, otitis media. Now we have this controversy of should antibiotics be given at all ages? If we give an antibiotic, which antibiotic? At what dose? Should we give a smaller dose of 40 milligram or 90 milligram of amoxicillin? How long do we give? Is it for 3 days, 5 days, 7 days, 10 days? So let us look at the guidelines. Guidelines say that acute otitis media should not be diagnosed in the absence of middle ear effusion. That means you must demonstrate that there is fluid in the middle ear, which is detected by pneumatic otoscopy or tympanometry. This is a strong recommendation. In our country, only 50% of pediatricians have otoscopes. So a diagnosis of otitis media is also not made at all properly. Second is antibiotics are usually indicated in small infants. This is without any doubt on this. However, if you look at the next recommendation, antibiotics should be given to children aged 6 to 24 months with bilateral otitis media and any child with moderate or severe otalgia. Again, very subjective criteria. Otalgia more than 48 hours, again subjective, and temperature more than 102. This is rarely followed in practice. Very often what we do is a child has cough cold, has a little ear pain, we start an antibiotic. So therefore, we don't follow the recommendations very clearly. Waitful watching. I am sure that most of us do not follow these recommendations, especially for older children, of watchful waiting. Primarily because we do not have the time, and 2, patients don't come back for follow-up very often in our practice. So this is another issue. Now, if a decision is made, the best drug to start is amoxicillin. This is a recommendation. However, if you look at the survey done, a large survey was done to look at both general practitioners and pediatricians, and the majority of pediatricians would start with co-amoxiclav and not amoxicillin. Another thing is, consider cephalosporin if a child only has a severe allergic response to penicillin. In our country, cefixime is used left, right, and center. The commonest antibiotic which is used for any upper respiratory infection in routine practice is cefixime. And we know very well that cefixime is a worthless antibiotic as far as otitis media is concerned, because it has no action against Streptococcus pneumoniae. Then we have duration of 5 to 10 days. Most patients are non-adherent. If you give any antibiotic for more than 3 to 5 days, patients rarely stick to medications. So you see the gaps in our treatment are phenomenal. Next step is, let's look at otitis media with effusion. Now, do you want all patients with otitis media with effusion to go in for Grommet tubes? What are the recommendations? It says very clearly, tympanostomy tubes should be offered to children who have got recurrent otitis media, but also have got effusion and also are at risk for various disabilities. However, this is rarely followed because this decision is taken by ENT surgeons and rarely by pediatricians. So here again, it's very, very important that pediatricians look at children carefully and not send every patient who's got a media with effusion for a Grommet placement. Coming to sinusitis, there's even more confusion. The 4-year-old boy with rhinitis for about 10 days, mild fever on and off, nasal block for 2 days. The CT scan shows mucosal thickening of the maxillary sinuses. So what would be the best therapeutic option here? The basic thing here is, once you put in a scan or an X-ray, you will find some kind of abnormality in the sinuses, which is not really bacterial infection, because the mucosa of the sinuses are going to hypertrophy even in the presence of a viral infection or even an allergy. So therefore, imaging studies should not be done in most cases of sinusitis, which is very often not followed. Now we all know that most patients with sinusitis are either post-viral or allergic in nature. We have to use a judicious use of antibiotics. This is a recommendation. However, antibiotics are given frequently, even for a yellow nasal discharge. Even if this child has no fever, if this child has got no pain in the sinuses, no facial tenderness, still we start antibiotics. Watchful waiting in non-severe cases is the recommendation, but we rarely implement this, again for reasons I have already mentioned. So therefore, if you look at sinusitis, again, the starting point should be amoxicillin. However, most of the time, co-amoxiclav is the starting point for most patients with sinusitis. So as you can see here, there's a huge gap between what the recommendations are, however imperfect, and what practice is. Now let's look at the allergic rhinitis. So, or let's look at snoring, sorry, not allergic, but look at snoring. Now in snoring, one of the recommendations is to use intranasal steroids. But what does Cochrane say? There is insufficient evidence to evaluate the efficacy of intranasal corticosteroids for treatment of OSA. However, they work best when there's adenoidal hypertrophy coexistent with allergic rhinitis. So it's a small subset of patients who have got OSA, who also have allergy, who will respond very well to intranasal corticosteroids. But what are we doing? Every patient who's got an adenoidal hypertrophy is put on corticosteroids. Now I'll go to the next. Montelukast can improve the apnea-hypopnea index in non-severe OSA. This is the evidence which has come out quite recently. However, we also know that Montelukast has got significant side effects, and we do not monitor this on a regular basis because there are subtle side effects like behavioral issues. The child may change the behavior or may have insomnia. Therefore, it's very, very important that Montelukast is used very sparingly. The other thing which we should look at is cough syrups. This is the third point which I wanted to come. And cough syrups are dangerous, and FDA has said very clearly that most cough syrups should not be used in children under the age of 4 years of age, and especially under children who are less than 2 years of age. And no cough suppressants, especially codeine containing cough suppressants, because they are associated with increased mortality. However, in India, cough syrups are still used quite often. They are growing at a huge rate of almost 5% every year. And they also contain many other components like active ingredients like sweeteners, thickeners, flavors, colors, antimicrobials, buffers, etc. So therefore, we have to be very careful about not using cough syrups in our practice. Coming to allergic rhinitis, this is another very interesting field which has got a lot of interventions which have been looked at, like intranasal corticosteroids, locally active antihistaminics, combinations of corticosteroids and antihistaminics, oral antihistaminics, leukotriene antagonists, immunotherapy, saline irrigation, allergy avoidance. What evidence do we have of the usage of this? Intranasal corticosteroids are very useful. They are the most effective when used continuously, but they can also be used on as needed basis. And therefore, in children who have got seasonal rhinitis, it is better not to use them on a continuous basis because they have their own side effects. Intranasal antihistaminics are not very acceptable, but they also are an alternative and can be used for allergic rhinitis. There's a very good, strong recommendation on this. The combination, however, is not really very useful, but we still continue to use the combination of intranasal corticosteroid with antihistaminics. Oral antihistaminics do not have very good evidence to suggest they work, primarily because they have no action against nasal congestion. However, we still use a large number of second generation antihistaminics like cetirizine, loratadine, fexofenadine, etc. What about decongestants? Well, again, they can give some symptom relief, but again, the recommendation for the use of this is pretty weak. What about intranasal decongestants? We also use things like oxymetazoline, like local sprays. But again, short-term usage may be acceptable, but not long-term. Now, as far as leukotriene antagonists is concerned, they are less effective than intranasal steroids. Again, recommendation is weak. We do not have many recommendations, and Montelukast has the black box warning that it has got mood-changing behavior. Now, immunotherapy, there's a lot of talks which are going on about immunotherapy, but the recommendation that it really works is very specific only for a few causative allergens and not as a blanket treatment for allergic rhinitis. Nasal irrigation, many people are using now to keep the nose clear. Recommendation, again, evidence very poor. Now look at allergen avoidance. Environmental control for perennial allergic rhinitis may help only if there is an animal allergen identified. Other things have got, again, a very weak recommendation in terms of avoidance. Now, Dr. Sukumaran was mentioning about asthma. Asthma is a huge topic. If I start talking about asthma and its controversies, it will take me at least an hour. So I'm going to touch upon what are the issues in the managing wheezing in children under 5, because this, I think, is a major issue. And I'm going to touch upon controller medications more than the reliever medications. We are always in a quandary when to start, how to step up, what to add, how to step down, and when to stop. Let's start looking at at what are the recommendations. Now, GINA guidelines do not recommend the use of oral bronchodilator therapy due to slower onset of action and higher rate of adverse reactions compared to inhaled SABAs. Now, I would like to ask every pediatrician here that if you find a child under 5 who's coming to you with an occasional intermittent cough and wheezing, all of us use oral bronchodilators. Every one of us is using an oral bronchodilator because to get a parent to accept an inhaler treatment for a very infrequent wheeze is almost impossible. So the guidelines say one thing, but what we do is practice again is very different. The second thing is the diagnosis of asthma in an under 5 is wrought with so many problems. And finally, when we say, okay, a child is getting recurrent wheezing, it is coming without fever, and there are other atopic markers, and when there is the asthma predictive index, which is fairly strong, you start with an empiric treatment. You start initial treatment. What is the evidence for this? Again, very, very little. Now, again, if you look at the GINA guidelines, another thing which it says is against routine use of sustained release theophylline. Whereas if you look at the British Thoracic Society, they say consider use theophylline. So again, there is a big difference in the guidelines itself, which means that the evidence for this is not really complete. Then mast cell stabilizers, of course, we don't get in this country any longer, but the Americans are pretty gung-ho about using the mast cell stabilizers. So there is a lot of dichotomy even in the recommendations and the interpretation of evidence as far as this is concerned. Again, the other issue which we looked at is, for example, when you are using the step-up treatment, when you are going to, let's say, step 3, again you say here use the double dose of ICS used in step 2. That means you don't go to medium dose, but you double the dose of low dose ICS. Again, that is a recommendation which has come recently. Very little evidence. If you look at the evidence level, it is again C and D. British Thoracic Society says that you add a leukotriene antagonist and don't worry about increasing the dose of corticosteroids. So there are a lot of confusing messages because of the varying ways that people are looking at the evidence. Then again, if you look as the asthma progresses in children under 5 years of age, you have more and more recommendations coming in which are difficult to follow. Like, for example, referring to an asthma specialist. Now, how many asthma specialists are there in this country? Very few. If you look at the number of pulmonologists, very few. So therefore, again, this is a problem which we need to look at. Then coming again to, if you look at many of the recommendations there, all of them have got evidence level of D, which means that the evidence is very, very poor. So therefore, the management of both under 5 wheezing and the management of asthma in older children is still an evolving science, because there are so many things, as Dr. Sukumaran mentioned, the usage of formoterol with a steroid, corticosteroid, with budesonide, is a smart therapy which is well recommended in children who are above 12 years of age. However, in smaller children, the studies have just started now. So we will know whether we need to give, every time that a child gets wheezing, whether we need to give a steroid. So I think these are all evidences which are still in referral. And as we go further, many other things are still not issued. Now let's come to another very problematic area, and that's community acquired pneumonia in children less than 5 years of age. As far as definition is concerned, a group of experts met a couple of years back, and they were unable to come with a consensus of what the definition of pneumonia was. And that is the reason why you will have different people giving different recommendations. Now you look at antibiotic guidelines. Again, they are very, very different. I'm just going to touch upon. The next step is to give or not to give. Certain guidelines say give the antibiotic. Certain of them say don't give. If you say which antibiotic, are you going to give 1 antibiotic or 2 antibiotics? What is the dose and for how long? Again, a lot of confusion as far as the community acquired pneumonia is concerned. Let's start with the British Thoracic Society guidelines, and says that all children who have got definite diagnosis of pneumonia should get antibiotics. However, the BTS says that it is not routinely required in young children under 5 years of age because viral pathogens are responsible for most clinical diseases in the age group. Okay. The next thing it says is oral amoxicillin is the usual first empiric antibiotic in children less than 5 years of age, and amoxicillin and macrolides in older children. Macrolides are generally recommended for suspected atypical bacterial pneumonia or severe disease. Bacterial infection and resistance patterns varies from region to region. So therefore, we have recommendations which are coming out which say that you may or may not give antibiotics, you may give different antibiotics, and you need to understand the local resistance patterns before you give an antibiotic. Now let's see what the Pediatric Infectious Disease Society and the IDSA say, that children less than between 3 months and 5 years should be given amoxicillin 90 mg per kg per day, orally in 2 divided doses for presumed bacterial pneumonia. The alternative is co-amoxiclav. Macrolides for presumed atypical pneumonia, again moderate quality evidence, and antimicrobial therapy not routinely required in preschool age children. So therefore, we have a lot of different messages which are coming through. Finally, let's go to WHO. WHO classifies pneumonia only into 2 categories now, and it says that use amoxicillin 50 mg per kg per day in 2 divided doses for 3 days. The recommendation is 3 days, and 5 days in areas where there is high HIV prevalence for children aged 2 to 59 months. And where did this 3 days come from? It came from 2 studies, one from Pakistan and another from Malawi, which showed that there was no great difference between a 3-day and a 5-day course of antibiotics. However, how many of these children who came with fever and tachypnea and retractions were really bacterial pneumonias? We do not have data on this. So unless we are very clear that how many of these were bacterial pneumonias, how many of these were viral pneumonias, and how many of these were wheezing induced viral infections, it's very difficult to really make a recommendation on the treatment of bacterial pneumonia. So what we have looked at in the last 15 minutes is we have looked at otitis media, looked at sinusitis, looked at sleep disordered breathing, looked at cough, looked at allergic rhinitis, looked at preschool wheeze and community acquired pneumonia. So my question to the organizers are there any clearly resolved issues in pediatric respiratory therapeutics? And I'm sure each one of us, if we scan deeply within, will know that there are no certain answers for most of the things that we do. We are following some guidelines. Our patients are getting better with or without treatment, and we do not know why they get better, but they are getting better. So I think what we need to do is to probably do more research to get more quality evidence from our country rather than rely entirely on what the West is telling us. Unfortunately, the number of research papers in pulmonology from our country is very limited. So real knowledge ultimately is to know the extent of one's ignorance. And I think that's what I've tried to portray in the last few slides, that we are probably pretty ignorant about most of the things that we do. So what is the opposite of ignorance? Well, education, knowledge, cognizance, literacy, wisdom, experience, intelligence, familiarity, talent. So we need a lot of things that we need to get rid of this ignorance. However, some of the other parts of evidence-based medicine is, well, the drug representative gave me this shiny brochure and a lavish lunch and said it was the best drug to prescribe. That's one kind of evidence. The other is I've practiced this field of medicine for 30 years and I've always prescribed it that way. That's another form of evidence. The third is I found a single case study in a random journal which supports the unlicensed use of this drug, is another type of evidence. And finally, a student says my consultant asked me to prescribe it. So that's another form of evidence. So ultimately, evidence is the integration of the best research evidence within your own country with clinical expertise and patient values. In India, in addition, we are unique. We have different definition of evidence. We have a very unique definition of evidence, and there it is. The first evidence for medicine for COVID-19, we have a very nice form of evidence which is there. So thank you very much for a patient hearing.
Thank you, Dr. Jagadish, for an excellent presentation of this topic. Again, after talk also, most of the problems remains unresolved, and we will have a discussion of the topic. There are few questions in the chat box, and there's a question from Balachandran. He said, if cough syrups cannot be used, especially in children less than 2 years, why it is not banned by DCIG? Why cough syrup is not banned?
Well, the answer to that question is probably because we are not strong advocates to ban it, because we have got ambivalent this thing towards cough syrups. Though we say in academic platforms not to use cough syrups, and everybody when he goes back to his practice will definitely give a cough syrup to allay the anxiety of the mother, because you need to give something to keep that baby comfortable, the mother comfortable, so you give a cough syrup. So that's the reason why we do not advocate to ban this medication. Ultimately, the banning of codeine containing cough syrups was because of a public interest litigation and somebody raising a voice against the against codeine as a cough syrup. Of course, it is a huge economic loss for the companies involved, but ultimately it got banned.
Jagadish, another question. For less than 2 years, if the baby is having repeated cough, what should be given? What is to be done?
Yeah, so I think the first step is
Interesting
diagnosis.
question. Same.
Why. So the first step is always diagnosis as to why the child is getting recurrent cough. If the child is getting recurrent cough, the common causes are three. One is if it is upper airway cough syndrome, there is something irritating the upper airway and producing cough. Two is gastroesophageal reflux disease, and third is hyperreactive airway disease. All three are possible, and it's very important to look at all these three things before you decide to start treating this child. And much of this cough one should look for is prevention, because there could be environmental factors, smoke, parental smoking, dust, wrong feeding practices. So there are many factors which could be the cause of this child's cough. An accurate diagnosis is more important than giving medicines.
Any other questions from the audience? If there are no more questions, I want to summarize this talk. Dr. Jagadish has taken up almost all common conditions in the respiratory system. Regarding acute otitis media, his favorite topic, I have seen Dr. Jagadish talking a number of times on acute otitis media. Again, he has highlighted the importance of not using cefixime. Among the third generation cephalosporin, cefixime is not going to be effective. Cefixime is mainly used for infection just below the diaphragm, not above the diaphragm. And also, azithromycin should not be used unless the child is allergic to penicillin. Regarding sinusitis, he has highlighted the importance of not taking a CT scan or X-ray. Investigations are not required. It is mainly a clinical diagnosis. All children, if you take a CT of the sinuses, some degree of inflammation is there, some degree of mucosal thickening is there. So this is not required for our children. Then regarding adenohypertrophy, he has again highlighted the importance of intranasal steroids. Intranasal steroids are useful in adenohypertrophy, especially in presence of obstructive sleep apnea syndrome. Intranasal steroids are going to be effective. Again, he has highlighted the importance of montelukast. Montelukast is the drug that we write left and right throughout the country. A lot of companies are coming up with the combination of montelukast with levocetirizine. Montelukast can produce a lot of neuropsychiatric manifestations like hyperactivity, insomnia, poor scholastic performance, suicidal tendency, etc. And also companies are coming with a combination of montelukast with antihistamines like levocetirizine and fexofenadine. It should not be used. It is not a rational combination. Then cough syrups, there is not much use for cough syrups, especially cough syrups contain antihistamines. We use antihistamines, a combination of chlorpheniramine maleate with pseudoephedrine and others. Especially should not be used for children less than 6 months. In children less than 6 months, don't use any antihistamines, including second generation antihistamines and cough syrups containing antihistamines. Allergic rhinitis, yes, again described the drug of choice is allergic rhinitis, intranasal steroids, and there is a controversy on immunotherapy. He has highlighted that in allergic rhinitis, immunotherapy is indicated in moderate to severe allergic rhinitis, in which the etiological factor is 2 or 3 allergens. If only less than 2 or 3 allergens are detected, you may go for an immunotherapy. Under 5 weeks, again, he has highlighted the importance of inhaled corticosteroids in children with recurrent episodes of wheezing. Regarding theophylline there are again controversies there. GINA guidelines say that theophylline should not be used in children less than 12 years. Both theophylline, orthotheophylline, and aminophylline, there is no role for it. And regarding community-acquired pneumonia, also again controversial. And the previous WHO guidelines say that we should give 80 to 90 milligram per kilogram body weight of amoxicillin. Now it is only 50 milligram per kilogram body weight, 12th hourly. And also, he has again highlighted that in all respiratory infection, I think both upper and lower, the first track of choice should be amoxicillin. You should not go for higher antibiotic. Thank you once again for your patient listening. Thank you, Jagdish Chinappa, for excellent presentation. And thank you, Dr. Lalitha, for the opportunity given to me. Thank you very much.
So thank you. Thank you, Dr. Jagdish Chinappa, for that excellent deliberation, and Dr. Sukumaran for nicely summing up the points that Dr. Chinappa had made out. But as he had mentioned, I think still many of the respiratory therapeutics remain unresolved. I think let us hope for more research evidence. So with that, thank you both of you once again, and let us move on to the next scientific program. The next session we are going to have is another exciting one, that is what is new in vaccinology 2020 and 21. We are going to hear straight away from the horse's mouth, that is the convener of ACVIP, Dr. S.D. Kashi. And to chair the session, we have Dr. Riaz, Associate Professor of Pediatrics, as well as Endocrinology, Government Medical College Trivandrum, as well as the National Executive Board member. Now, the session is to carry forward the session. May I invite Dr. Riaz to introduce the speaker as well as to introduce the topic. Over to you, Riaz.
Thank you, madam. So we are moving to yet another controversial area in the pediatrics. Vaccination being a very primary responsibility of pediatrician, all of us should be sure about what to give at what time. And we have an excellent faculty with us, because I know all of you may be knowing that in the Pedicon sessions, whenever there is a national Pedicon session, there will be an exodus of attendees from one hall to another when Dr. Kashi is talking, because he moderates sessions on vaccination as well as asthma in an excellent manner. And sir has been the convener of ACVIP, and multiple times he has been the member of our IAP committee on immunization. Over to Dr. Kashi for telling us what is new and what is the best practice in immunization. Thank you, sir.
Thank you, Dr. Riaz. I will share my screen now.
Okay, sir.
Visible, sir? Visible.
Oh, yeah. Thank you. So initially, my profound thanks to Dr. Lalitha and her team for giving me this invitation to address this very popular CME. I also extend my greetings to all the dignitaries and the attendees of this particular webinar. My compliments to the previous two speakers, Dr. Nita for that extremely practical talk, and of course, Dr. Jagdish for that extremely thought-provoking talk. So when I was asked to talk on what's new in vaccinology, I thought I will concentrate on two parts. One is the recent ACVIP 2021 recommendations, which is going to be the main focus of my talk. And if time permits, I will talk something about the new developments that have occurred in vaccinology with reference to the COVID vaccines. Now, the recommendations were published in the Indian Pediatrics in January, but they were available in a preprint in the Indian Pediatrics site sometime in November, since when these particular recommendations became operational. The main recommendations were changes in the polio immunization schedule, a change in the inactivated influenza vaccine dosing, a change in the recommendations regarding the timing of the second dose of varicella vaccine, and there was some introduction to some of the newer vaccines that have been introduced in the Indian market over the past 1 to 2 years. Today, I'll be concentrating mainly on the recommendations. I will not talk about individual vaccines. Before I go any further, I would like to make it very clear that the ACVIP recommends what is best for an individual practice. That means once the ACVIP makes the recommendations, there is no ambiguity about the benefits and the completeness of these recommendations. On the other hand, this is in contrast to public health recommendation, which recommend what is of acceptable benefit to the majority in the most cost-effective manner. So as far as public health is concerned, the WHO recommendations is the ideal. Whereas as far as the ACVIP recommendations, I think we sort of take more guidance from the CDC and the ACIP, that is American Committee of Immunization Practices recommendations, which usually go for the best in individual practice. I think if we keep this in mind, we can understand and interpret a lot of dichotomy that exists in the immunization recommendations as far as UIP and the IAP is concerned. So let's come to the polio. The ACVIP has now recommended a boost of the injectable polio vaccine at 4 to 6 years. In 2008 till 2018, there was a recommendation for an OPV at the age of 4 to 6 years. In 2018, this particular recommendation was dropped with a view to reduce the usage of the OPV vaccines. Now, this particular ACVIP felt that there is some lacuna over here, and we need to fill this gap with some recommendation. Either give a polio vaccine or do not give the polio vaccine. And we did a very, very systematic literature search and made these particular recommendations. We must remember, for successful polio eradication, what is paramount is achieving and maintaining sustained high levels of population immunity until we have no wild polio and no CDPV. And this has to stop all over the world, because if polio is there anywhere in the world, the entire world is at risk. And we must remember that in areas where there's no wild polio virus, like it is in India for the past 7 years, the vaccines are the only source of protection against polio. We do not get any polio virus from the environment now. And thus, it is very imperative to have foolproof polio vaccine schedules. Now, what happens after you give the primary dose of the polio vaccine? If you look at this particular graph, sorry, I'll just put the pointer. Yeah. Now, if you look, following the primary vaccination schedule, everyone seroconverts. I'm talking about a 246 schedule. This is an European schedule. Very high antibody titers are raised. But by the time it is time for the first booster, although the seroprotection rate falls very little, there is a very drastic fall in antibody titers for all the 3 serotypes. Once you give a booster dose, there is a very strong anamnestic reactions to all the 3 polio types. Seroconversion rates reaches 100% and antibody titers shoots to very high levels. And this is true for both AP and WP vaccines. So now you give a toddler booster, that is somewhere at about 15 to 18 months. After you give a toddler booster, what happens? No one has studied what happens after a toddler booster, because all countries using IPV have always given a booster at 4 to 6 years. So what happens after you give the second booster at 4 to 6 years? Yes, 1 year later, the seroconversion rates remain static at about 100% for at least till 5 years of follow-up. Initially, there's a very remarkable drop in the antibody titers, which is true for any protein vaccines. And then the titers remain almost constant till about 5 years for all the 3 schedules, for all the 3 polio types. Beyond 5 years, there are no studies about the persistence of antibody titers following the 4 to 6 year booster dose of IPV. What happens if you don't give an IPV vaccine at 4 to 6 years? So this is a study in Germany, a rather smaller study, where they looked at the polio seroprotective titers in children 7 to 9 years old who had not received a booster at 4 to 6 years. And you will find that in those who are not received a booster, the seroprotection rates against type 1 and type 2 falls to around 91%. And believe me, when you're talking about polio immunity induced only by vaccines, this is not sufficient. On the other hand, boosted infants had 100% seroprotective titers. We should also remember that there are no studies regarding the long-term persistence of antibodies with the EPI schedule or the 6-10-14 schedule or the 2-dose of fractional dose intradermal IPV. Okay. The next, is it important to have high titers of antibodies or is just priming enough to protect against polio? There are some studies. We must remember that in the present situation, it is not just protection against paralytic polio that is important. Our problem today is not wild polio. It is circulating vaccine-derived polio. And for protection against this, we require a strong gut immunity. We know that IPV is not as good as OPV, but it is better than no vaccine. We also know that pharyngeal immunity is better than gut immunity as far as IPV is concerned. The question is there any correlation between pre-existing antibody titers and the intestinal excretion of polio virus following a challenge dose? And this was an old study done in 1969, where they found that the pre-existing titers definitely had a correlation with excretion of polio virus in the intestines. Those with the lowest titers had the highest excretion. Those with the highest titers had the lowest excretion. And this correlation was strongest for type 1, to some extent for type 3, but not very significant for type 2. Another study, again done with a similar profile, but where they studied both the pharyngeal and stool excretion, they found that pharyngeal excretion is reduced even with moderate titers of pre-existing antibodies, but to reduce the stool excretion, you need high titers of pre-existing antibody, indicating that high titers of pre-existing antibodies do contribute to the intestinal mucosal immunity, which is of very great importance in today's scenario in our country. Taking all these into consideration, before the last position paper in 2016, the WHO published this statement where they looked at the evidence available regarding the long-term duration of IPV, and what they found that the numeral quality of evidence was just moderate, and there was low scientific evidence for greater than 80% long-term persistence of protective antibodies following more than 3 to 4 doses. And so the data till date suggests that overall studies show that the persistence of polio neutralizing antibodies is well established at least until school entry age by the 3+1, 2+1 or a 3+0 schedule. IAP is following the 3+1 schedule with slightly higher titers in favor of the most complete schedule. A minimal position would be to recommend 4 to 5 doses of a IPV containing vaccine with the last one administered at school age entry. Here, I would like to make a comment that there are studies which have dropped the toddler booster at 12 to 15 months and seen when is the best time to give it. And studies show that even if you drop the toddler booster, a preschool booster is extremely important to maintain high antibody titers for the reasonably long period. So with all this evidence, the ACIP has recommended a booster dose of IPV at 4 to 6 years of age for children who have received the initial IPV doses as per the ACVIP IAP schedule. That means these children have received 3 IPV at 6, 10, 14 and 1 IPV between 15 and 18 months. That is as far as the IPV. We have also said that it is extremely important that IPV should be given to each and every child today, because otherwise OPV is only bivalent. There is no protection against type 2 at all. Let's look at the figures. This is a WHO chart with data as recent as 23rd March 2021. And just look at these figures. Look at the type 2 CDPV. It is going on increasing. And in 2020, we had over 1,000 cases of CDPV. And remember, before the switch occurred, what was the projection? CDPV risk may persist at last not more than 1.5 years. By then, whatever type 2 is there in the environment because of the oral polio, It will disintegrate, disappear, and we will not have any type 2 CDP. But this has been proved totally wrong. So it is absolutely necessary to have protection against type 2 today. And that can be achieved only with the injectable polio vaccine. So with this in mind, the ACVIP recommended that no child should be administered only pentavalent vaccine and the bivalent oral polio in infancy without the IPV, any form of IPV. If the hexavalent vaccines are unaffordable or unavailable, the infant must be referred to a government healthcare facility for the primary immunization as per the UIP schedule. You should not administer only pentavalent vaccine and BOPV and just wait. Infants and young children born after the switch who have not received IPV in any schedule should receive at least one dose of an IPV or IPV combination vaccine intramuscularly at the earliest opportunity. The ACVIP emphasizes intramuscular because there is more robust data and long-term data with the IM dosing rather than the intradermal dosing. Now we come to the second change. What should be the schedule of the varicella vaccine? We are very used to giving it at 4 to 5 years, but we should remember that these recommendations were made by the American authorities based on data and the need in that particular country. So what will decide when you should give? See, any vaccine, you have primary vaccine failure and waning immunity. Now, if it is a primary vaccine failure, the breakthrough varicella will be highest in the first few years, gradually fall and ultimately come down to very low levels. On the other hand, if it is waning immunity, there's a gradual rise in breakthrough in varicella, which increases year to year. Now, what is the data regarding varicella vaccine? This is a study which looked at breakthrough varicella over 14 years in vaccinated children. And as you will notice, the maximum incidence of breakthrough varicella is in the first 4 to 5 years, followed by a more gradual fall and very low levels by the end of 14 years, again favoring a primary vaccine failure rather than a waning immunity. This was a study where they looked at the effectiveness of varicella vaccine by time since vaccination, a very elaborate study where varicella was proved by PCR of the vesicular fluid and not a clinical diagnosis. And what they found that at the end of 1 year after vaccination, the effectiveness was 97%. By 2 years, there was a drop to 86%, and then the effectiveness remained fairly stationary till about 8 years. Again, this data favors a primary vaccine failure and not a secondary vaccine failure. So generally in this review article, it concluded that literature to date indicates a relatively high rate of primary vaccine failure, and there was very limited evidence of a secondary vaccine failure among one-dose varicella vaccine recipients, suggesting a shorter interval between the two doses might be preferable. Again, I would like to emphasize where you have primary vaccine failure, a short interval is preferable. When you have a waning immunity, you require a longer interval. So this is the reason why, moreover, if you see, children all over our country, at least children catered to by the private sector of vaccines, go to school between 2 to 3 years and they get exposed and they land up with breakthrough varicella. And remember, as far as the ACVIP's recommendations for best practice, it is not just preventing varicella complication. We want to prevent all varicella, and that can only be achieved by giving the second dose as early as possible, preferably 3 to 6 months after the first dose. Even a week, interval of 4 weeks is preferable, but 3 to 6 weeks is what is preferred. 4 weeks may be acceptable, but not the standard. Okay. The next recommendation is about the inactivated influenza vaccine. The ACVIP has recommended give 0.5 ml to all, no 0.25 ml between 6 and 35 months. Now, why? Remember, this recommendation of differential dosing was based an old recommendation based on the wholesale influenza vaccines, which were extremely reactogenic, gave rise to high incidence of febrile conversion. So they reduced the dose in those less than 36 months of age. So it was 0.25 ml from 6 to 35 months, and above 36 months, it was 0.5 ml. All these vaccines now have been replaced with the modern vaccines, which are either subunit or split virus vaccines. We also know that the very youngest infants, especially those between 6 and 11 months, the immune response against these particular types of influenza, and especially against the vaccine B strain, is not very, very robust. Moreover, some pilot studies have shown that the reactogenicity of 0.5 ml is no different from 0.25 ml in this particular age group. Looking at this, two major studies have been done. One was done by Swarovski et al., and this was with the trivalent vaccine, where they found that in the 6 to 11 months, giving the full dose conferred statistically superior results, efficacy, compared to the half dose as far as H3N2 and the type B was concerned, but this statistical difference was not achieved in those with H1N1. Okay. Now, if you look at the 12 and 23 months, there was no significant difference in efficacy between 0.25 and 0.5, but there was no increased reactogenicity by giving 0.5 ml in the youngest infants. Another large study was done in USA, where they compared the quadrivalent influenza vaccine 0.25 versus 0.5. And what they found, specifically the B strains, seroconversion rates, seroprotection rates, and the mean geometric increase in the GMTs were higher in the double dose group compared to the standard dose in children between 6 and 35 months, and all these were statistically significant. So summarizing, generally immune response is better with 0.5 ml. There is no increased reactogenicity. Generally, more and more countries, including the WHO, has recommended a uniform dosing. Even the DCJ has approved this. And with all this, the ACVIP also endorses a uniform dosing schedule of 0.5 ml or 15 micrograms for all children older than 6 months. I do know that there are some brands which are still not got the DCJ approval, but I think it's a matter of time before they get, and all the brands available in the country will now have a 0.5 ml recommendations for all ages. So having first completed with the first part, I will now briefly discuss about some new developments in vaccinology regarding COVID vaccines. I'm not going to discuss individual vaccines. I think there have been a lot of discussion about it. I'm going to discuss something about the new platforms, the new timelines, and something very new that has emerged about equitable distribution, which has never occurred so far as global vaccine coverage is concerned. We are very familiar with the killed attenuated protein subunit, but what we are seeing today is the genetic vaccines and the viral vector vaccines. Now, what is a viral vector vaccine? You take a viral vector, in this case, maybe the chimpanzee adenovirus, you remove the genes which causes multiplication. In its place, you insert the gene responsible for production of the S protein or the receptor binding domain. So you get a hybrid virus, a vector virus, carrying the genes for the S protein. You inject it into the host. The host produces S protein. That S protein is recognized as a foreign protein, elicits an immune response, and you get antibodies and T cell responses. Now, this viral vector can either be replicating or non-replicating. Most of the present viral vector COVID vaccines today are all non-replicating, although there are at least about 3 vaccines which are exploring viral vectors. Now, this is not new. The present existing Ebola vaccine is a viral vector vaccines. And now we have quite a few of these COVID vaccines which are viral vectored, and many more coming up with many more viruses, not just measles virus, rabies virus, many other viruses are being explored as viral vectors for COVID vaccines. We must remember that viral vaccines, because the antigen presentation is intracellular, it elicits a type 1 MHC class 1 response, and you get very, very robust T cell response and a very strong B cell response. We know that these viral vectors are safe. They have been extensively investigated for many other vaccines. But the one drawback is if you have strong adenoviral vector antibodies in your body, it may dampen the response to this vaccine. And the other advantage, these can be stored at 2 to 8 degrees, where there's plenty of facilities for us in our country. Now, coming to the nucleic acid vaccines, what is a DNA vaccine? You take the DNA of the S protein, you insert that into a plasmid. A plasmid is an extra chromosomal DNA which does not take part in replication. You cover it with a liposome so that that DNA is not destroyed in the cytoplasm. You inject it, either the myocytes or by electroporation. It enters the cell, passes through the endosome, enters the nucleus. In the nucleus, the DNA undergoes bifurcation, giving rise to the messenger RNA, which is extruded out in the cytoplasm. In the cytoplasm, the mRNA goes and gets attached to the endoplasmic reticulum, where the synthesis of amino acids and proteins takes place. Again, this protein is a foreign protein. So it is thrown out, recognized by the immune cells of the host, and you get a good immunological response. Again, it is a MSC class 1 response. So very, very robust T cell responses. Now, looking at the mRNA vaccine, which are in use today, it is very similar. You take the mRNA, enclose it in a liposome, inject it, it passes the ribosome, and this is where the similarity ends. It does not enter the nucleus. It directly goes and gets attached to the endoplasmic reticulum, and it produces the antigen, and you get an immune response. So the basic difference is there is no passage through the nucleus. And once there is no passage to the nucleus, the very fear of insertional mutagenesis does not exist. So the advantages of this is this vaccine is very, very easy to produce. You can scale up production rapidly. Suppose you get a variant virus, all you need to do is pick up the S protein gene of the variant virus, insert it into this particular plasmid, and produce a vaccine, which can be done very soon, very, very quickly. In fact, it's already beginning. Studies are beginning now. The only drawback is you have very, very strict storage conditions, -60, -70 degrees. As I said, there is no mutagenesis, and right now the Pfizer, BioNTech, and Moderna vaccines are the ones which are in clinical usage today. Many other platforms are in usage. Live attenuated vaccines are coming. We all know how do we attenuated live vaccines. We used to culture them in suboptimal conditions till they are no longer able to reproduce. But today we have a very modern technique. Genetics has changed everything. You have what is known as codon deoptimization. Now, every amino acid has more than one codon responsible for the production of that particular amino acids. Now, a particular microorganism will prefer a particular codon, and the other codons, it will set it aside. So what is codon deoptimization? You remove those preferred codons, replace it by the non-preferred codons. So you reduce the efficacy of the mRNA, you reduce its translation to proteins, and you get a less virus with reduced virulence, which is basically a live internet. And this codon deoptimization is a very, very upcoming technology. And today, even the novel oral polio vaccine, which is going to enter clinical usage very soon, is being produced by this particular codon deoptimizing technology. We are having replicating virus, VLP, cell-based vaccine, and the nasal vaccines. The other exciting thing is the speed at which these vaccines have been produced. Generally, a typical vaccine takes 5 to 2 years to produce, and all the phases go sequentially one after the other. But a lot of things have changed in the accelerated vaccine development. You have all the phases going parallel. I mean, by the time the preclinic is over, phase 1 has begun, somewhere midway phase 1, phase 2, somewhere midway phase 2, phase 3. Infrastructure development and manufacturing occurs even before the vaccine has been approved, as occurred with the Covishield vaccine. Quick approval and distribution. You have the EUA, which you're all familiar about. So within a year and a half, you have a new vaccine rolling out, and this can be judged. See, on 11 January 2020, the Chinese authorities published the genome of the coronavirus. Within 2 days, the mRNA for the vaccine is ready. And by 18 December, EUA was granted. So it took less than 10 months for the vaccine to come in clinical usage the moment the genetic structure of the particular virus was known. Extremely rapid pace of development. The other new issue is equitable distribution. Remember, the vaccines go first to the developed countries and many years later come to the developing countries. Even in a pandemic, we know H1N1, the developing countries received the vaccine when the pandemic was almost over. So what has happened now? Wealthy nations, which have only 13% of the world's population, have cornered more than half of the vaccine doses. And we must remember that everyone is to be vaccinated if everyone is to be safe. And Bill Gates said that vaccines and antivirals cannot go to the highest bidder. It has to go to people who really need it. So it has to be distributed properly. And for that, COVAX has been formed, which very laudable motives. And I think we should be proud that India has been a very strong participant of the COVAX, and Indian vaccines, India-made vaccines, close to 60 million doses have been supplied to over 71 countries. And many of them, the poorer countries of Africa and many in Southeast Asia who could never have dreamt of this vaccine. The next question is, why should I take the vaccine? COVID is mild, the disease is gone now, the vaccine is unsafe. Remember, there are many reasons why you give the vaccine. You may want to prevent infection, sterilizing immunity. You may want to prevent an asymptomatic from becoming symptomatic. You may want to prevent a symptomatic from getting hospitalized, a hospitalized patient from entering the ICU, and an ICU patient from dying. Please remember these vaccines, all vaccines studied, 100% effective preventing severe COVID and death, even with one dose, and even for the variant strains. So my friends, if you don't take a vaccine, this is the way. You have asymptomatic, mild disease, moderate disease, and severe disease. But if you take the vaccine, the vast majority of infections are asymptomatic, some mild, some severe, but absolutely no severe disease. So friends, get vaccinated, but remember, still wear a mask, stay 6 feet away from crowds, and observe hand hygiene. Thank you. And if there are any other questions, I'll be very happy to share.
Thank you, sir, for that insights into what is new in vaccination. And also a special thanks to pointing out a very pertinent issue of equity in vaccination. And regarding the questions, I have a few. I shall just, there are a few comments that everyone can read from the chat box. I will just read out the questions. In standalone IPV, in standalone IPV available in sufficient numbers throughout the country?
See, right now Serum Institute has released polio vac. They have released with assurance that there will be no shortage and no restriction of availability, at least for the next 2 to 3 years. And I think we are not experiencing any shortage. We are getting as much supply as we want. And this has really opened up a lot of permutations and combinations, even for those who have not received IPV in the past.
And one more question, sir. When you are giving a hexavalent vaccine, are you not concerned with the weaning of immunity to the acellular pertussis vaccines?
I think comparing acellular and wholesale again is opening up Pandora's box. But remember, even that waning immunity is taken care of by repeated doses, and the waning immunity occurs only for pertussis and not for the polio. Here we're talking about polio today. I mean, if the occasion arises, we can have a discussion of acellular versus wholesale. But I think as far as polio is concerned, there's no waning of immunity, whether you use acellular or wholesale pertussis combinations.
Okay, sir. There is one more question again about another vaccine, like B typhoid vaccine. So,
well, B typhoid vaccine is using a different conjugating protein, that is the CRM197, and the source of the VI antigen is the fruendi and not the Salmonella typhi. But it has been shown that the VI antigen from the fruendi is immunologically and structurally absolutely similar to the VI antigen from the wild Salmonella typhi. So the immunological response is going to be the same, and the WHO has very clearly recommended even this source for the VI antigen. So I don't think there's any issue. As far as CRM197, maybe there was some thought that it would be superior because there will be no epitope-induced carrier suppression compared to the other vaccines, but no studies have really demonstrated this particular advantage as far as typhoid vaccines are concerned.
So one more question. This is again regarding polio. This VDPV occurs when OPV coverage comes down. So we maximize coverage with OPV, then introduce IPV and maximize it, and then withdraw OPV. So
Right.
now as BDPV2 is increasing, should we think about reintroducing OPV2 for Sunday?
I think this is a very good question. Well, once the VDPV started increasing even 3 to 5 years after stopping type 2, when they examined the genetic lineage of these VDPVs, of the type 2 CDPVs, they found that all of them were related to the vaccine. They were not related to the environmental sample. They were related to the vaccine. So the answer lies in producing a vaccine which will not revert to neurovirulence. And that is where the WHO has produced, along with Holland, a novel OPV where the attenuation has occurred by the codon de-optimization technique, where it cannot back revert. And this novel oral polio has already completed phase 2 studies, and it is expected that maybe within a couple of months, this will receive emergency use listing by the WHO. And once this vaccine is available, the present attenuated monovalent type 2 OPV will disappear, and we will have a monovalent NOPV2 for tackling all CDPV outbreaks. And then it is hoped that this problem of increasing CDPV will be taken care of. OPV is necessary, but we require a different type of OPV, not the one that we're using.
Okay, sir. Thank you.
Thank you very much.
And if you can share the email, because there could be more questions also.
Okay, I'll send you Dr. Lalitha. I think Dr. Lalitha has my email.
Yes,
She can
yes.
definitely
Okay,
give them.
okay, we can share
I can
that.
share that too.
Okay.
Okay, thanks a lot. Thank you. Thank you.
Thank you.
Thank you.
So thank you, Dr. Kashi. As typical of you, it is a really excellent masterly overview of the topic. And thank you, Riaz, for effectively moderating the session. So thank you again.
Thank
Now,
you.
let
Thank
us
you.
move on to the, hope you are not late for rushing to another.
No, I'm well in
function.
time. Well in time. Thank you.
Thank you.
Thank you.
Now, let us move on to the next session of the day. We have another interesting session by Dr. John Mathai, another doyen in the field of pediatric gastroenterology, to talk to us on fatty liver, how dangerous it is. We know that after the COVID, and we are seeing so many children in our OPD who are obese, now becoming more obese, or who are normal, now becoming obese. But majority of them, at least significant number of them, have what ultrasound reported as a fatty liver. How dangerous is it? To enlighten on us, we have Dr. John Mathai, Professor and HOD of the Department of Pediatrics from PSD Medical College, Coimbatore. And we have, to chair the session, we have Dr. Shanavas with us. He's the Professor and HOD of the Department of Pediatrics, Government Medical College, Alappuzha, and an excellent academician and a clinician and a very dear teacher to all the students. I'm extremely happy to welcome Dr. Shanavas and carry on this session to introduce the speaker as well as the topic. Shanavas, please.
Good morning. I think I am audible.
Yeah, you're right.
So at the outset, I express my sincere thanks to Lalitha Madam for giving me this opportunity to chair the session. As we all know, as Madam has already mentioned, the incidence of obesity is higher in the list because of the COVID pandemic and the lockdown. So as we all know, there is a coexistence of fatty liver and COVID, and also the obesity. So we thought that it was a simple coexistence. The fatty liver and obesity is a coexistence, and there is no problem occur later. So recent researchers has put forward the facts that it is a progressive disorder and can produce all sorts of problems, just like that of just like that of alcoholic cirrhosis and other cirrhosis. To enlighten us, we have got the doyen of pediatric gastroenterologist, Dr. John Mathai. Sir is the current president of ISPAGAN, you know the ISPAGAN, and a former professor and head of department, PSD Medical College, Coimbatore. He has got about 51 publications in journals, and he has authored about 25 chapters in various journals. Presently, he is the chief editor of IAP textbook of pediatric gastroenterology, and he was the editor of the gastroenterology section of PG textbook of gastroenterology. Presently, sir is working in Masonic Children's Hospital, Coimbatore. Over to you, sir, for this session. Thank you.
Is my screen visible? I'm not able to see my slides. Can I share my slides?
No, sir. Screen is not visible, but you are audible.
I've shared my slides.
Praveen?
Something else is coming on.
Anil or Praveen, can you help?
Sir, you have to open the
it's coming. It's coming
in the background.
Sir, what you have to do?
1 second.
So what you wanted to do, sir?
No, I've shared my screen. Can you just put me back on?
You can share, sir. Your screen is visible on my screen right now. You have opened the Safari window, I feel. So you just minimize this.
1 second, 1 second.
You have actually opened the Safari window. Either you minimize it or you can close it.
1 second.
Now you will be able to do it.
The screen is with Dr. Praveen, I think. Yeah.
Now it is there. You just make it full screen.
Yeah, I'll do it. I think.
Yeah. Okay, sir. Thank you.
Yeah. Thank you. Good morning. Thank you, Dr. Shanavas and the organizing committee for giving me the privilege of this presentation. If somebody has listened to me last week at the West Bengal meeting, it was the same topic. So this may just be a bit of a repetition, but there's a lot of things common between Kerala and West Bengal. So I assume they've given me the same topic because of the same reason. Fatty liver in children is not uncommon. And it's something that's been around for a long time, except that it's got more attention now. The earlier terminology used to be NAFLD, that is non-alcoholic fatty liver disease. That terminology is obsolete because it's relevant for adult medicine, but not for pediatric. So we now have a better terminology. The NAFLD is gone, and we are going to call it pediatric fatty liver disease. Remember, this is not an internationally accepted terminology, but we will soon be moving towards that. And let's start with the case report. This 14-year-old boy was admitted some time ago with fever for 5 days and purpuric spots. His platelet count was 25,000. His ALT was in 2000s. Other liver functions were normal. IgG, IgM were positive. It was dengue season. A diagnosis of dengue fever was made. He improved with fluids. He was discharged on day 3 and his liver was about 5 centimeters. His platelet count improved very rapidly. The ALT declined to 546. 1 week later, it had come down even more. 3 weeks later, it had come down to 84. But surprisingly, even at 3 months, the ALT still remained elevated. Normally, for a dengue, the ALT or the liver enzyme should normalize within 14 days or maximum 3 weeks. The ultrasound had shown mild hepatomegaly with increased echogenicity. Some more details about him showed that he had a BMI of 35. His BP was upper limit of normal. He had acanthosis, slightly abnormal blood sugars. Cholesterol was upper limit of normal. Other markers for an enzyme elevation was negative. His fibroscan was normal. A diagnosis was made that he had dengue with a fatty liver disease. Not an uncommon presentation at all in our setup, because we don't do ultrasounds routinely for obese children. So an acute presentation of an illness when an ultrasound is done is a good way to pick up an underlying fatty liver disease. What were the 2 learning points I learned from that case? The first is that fatty liver may present as an acute or a chronic liver disease. Second, that a child who's got an underlying fatty liver disease is like one who has a chronic liver disease and it can make an acute liver disease like dengue more severe or more complicated. With this introduction, let's look at what is pediatric fatty liver disease. It's a spectrum of chronic liver disease. Remember that terminology, it's a spectrum of what is today considered a chronic liver disease, and it is seen most commonly in obesity-related metabolic syndrome. It's characterized by excess fat deposition in the liver, and it is not associated with any other cause like an infection, drug, or an autoimmune process with the potential for progression to cirrhosis. This is the best definition for a fatty liver disease, that it is a spectrum of chronic liver disease which, if untreated, can progress to cirrhosis. Now, what are the stages of fatty liver? This is called steatohepatosis. Normally, as you know, the fat has less than 5% the liver has less than 5% fat. Anything more than fat, 5% of fat, is what we call as fatty liver or steatohepatosis. And what you will find on a biopsy is this: simple macrovesicular fat accumulation. This is called steatohepatosis. The next stage of this chronic process is what we call steatohepatitis, when there is not only fatty liver, but there's also inflammation inside that fat. There is ballooning of the hepatocytes with this inflammatory infiltrate. As you can see from the previous slide, look at these slides, they're just harmless, just fat sitting there. Here the fat is getting mixed up with these inflammatory cells, and the fat, the liver hepatocytes, are also getting a little bit more ballooned out. The third phase is what we call NASH or hepatitis with fibrosis. And as you can see, not only do you see inflammatory cells, you can also see the fibrous tissue as marked out in the trichrome stain in blue. There's also, so there's fat in the liver, there's inflammation in the liver, there's also fibrosis in the liver. And this is the third stage called NASH with fibrosis. And finally, you reach the stage of cirrhosis from fatty liver. And very interestingly, when it goes into a cirrhosis, you will not find any more fat in the liver. That means the fat disappears, inflammation comes down, it goes into a stage of uncontrolled fibrogenesis. So at this point, if you do a biopsy, it's impossible to make out the etiology of this chronic liver disease. You will not know that it was fatty liver that triggered the cirrhosis. So what is the sequence of NASH? And I want you to carefully follow this with me. This is what a normal liver would look like. Then it goes into a stage of steatosis. That means the liver looks little fatty and the microscopy will show us fatty liver. Then it goes into a steatohepatitis, where the liver starts having inflammation, followed by fibrosis, and then into cirrhosis. Interestingly, once the child has gone into cirrhosis, you cannot reverse that process back to fibrosis. Can you reverse a fibrosis to a hepatitis? It's a chance. Most often you cannot. Early stages of fibrosis you might. Hepatitis to hepatosis, yes, is reversible. And fatty liver to a normal liver, yes, is definitely possible. So the aim of this presentation is to pick up a fatty liver early in its course. Ideally, pick it up at a fatty liver and reverse it to normal, or at worst, pick it up at the level of an enzyme elevation of ALT, like in the child that I presented in the index case, and get that child back to normal. And incidentally, the child was managed well and his liver came back to normal. But that's the sort of thing that we are expecting out of a presentation of fatty liver disease in children. Now, how does fatty liver occur? We now know that there's definitely a genetic factor. PNPLA3 is implicated, but there are many other causes as well. But genetic factor alone is not enough to develop fatty liver. There are definite environment influences which have to come over this genetic factor. And what are they? Poor quality diet, which means it's low in protein, high in fat and carbohydrate, with a positive caloric balance, which means that the expenditure of calories is less than what is optimal, and the person ends up with an additional calories than what he should should normally get. What does these three lead to? That means a genetic factor with an abnormal diet and lack of exercise lead to increase in adipose tissue. And what does that lead to? Two things. One is the free fatty acid levels in the blood will go up. And second, fat triggers insulin resistance in the tissues. And this leads to inflammation in the fat. And that is what is called adipositis. That is inflammatory fat. What does this also lead to? A decrease of adiponectin levels in the blood. When there's chronic inflammation in the fat, together with low adiponectin, it leads to a fatty liver. What's the correlation between weight and fatty liver? What's the correlation? Is there a correlation? Now, we now know that in most cases, hepatic fat or liver fat is a manifestation of metabolic syndrome. In overweight and obese young people, the incidence of fatty liver is 70%, while it's only 7% in people with normal weight. So it's not that fatty liver will occur only in obese people. No, it can occur also in normal weight people, but the chances are much, much less if you are normal weight. Normal weight people with fatty liver will present at a younger age. Means that in these people, it's the genetic influence that is more important. Below 3 years of age, this is very important to remember that for some reason, obesity does not produce obvious fatty liver. So if you have a 2.5-year-old child who's morbidly obese, you look for everything, you can't find, liver is normal, doesn't mean the child will not develop fatty liver. He does not have fatty liver now, but as he grows older, he will definitely develop a fatty liver. So below 3 years of age, even morbidly obese children do not have a fatty liver, but they will develop a fatty liver in due course of time. Is fatty liver primarily due to obesity? No, there are other causes. And these are a must to be ruled out before you say this is pediatric fatty liver or nutrition associated fatty liver. I've listed out causes, but I want you to remember three important things. One is Wilson's, second is glycogen storage disease, and third, and more commonly these days, is autoimmune hepatitis. So these are three hepatic diseases that can present to you with fatty liver. What are the non-hepatic causes? Again, a large number of them, but please remember 3 or 4. Diabetes mellitus is an important cause. HIV is another important cause. Adolescent girls, polycystic ovarian disease, and interestingly also rapid weight loss. Somebody who's obese rapidly loses weight. They may not have fatty liver in the beginning, but they will develop fatty liver in the due course of loss of weight. Is pediatric metabolic syndrome or fatty liver only a problem in the West? Everybody in the West is talking about it. They are talking about a pandemic of obesity in the West, a pandemic of fatty liver in the West. Is it only a problem in the West? No. This is a study from India among 616 school students. 198 of them were overweight, and the prevalence of fatty liver was 62% among those 198. That means almost 140 of those children already had a fatty liver. 50% were detected on ultrasound, and 1/3 already had a steatohepatitis, as shown by a elevated ALT. This is another study which was, again, I was part of this. School screening of 961 children in the below 10 group, 5 to 10 year group. Prevalence of 19% in those who are normal weight compared to around 46% in the overweight. And 8% of children in that age group also had a metabolic syndrome. So this is not a problem in the West. This is an emerging problem in our country, and it's only going to increase with time. And I'm sure that the corona epidemic inactivity has definitely made it much worse than what these figures are suggesting. When do you suspect fatty liver disease? That's the next question. Clinical setting is an overweight adolescent who you may find the liver on palpation, but this is the important finding. Hello?
You're audible, sir, now?
You're audible, sir.
My slide is not moving.
Yeah. This is the clinical setting. It's not moving now.
Yeah, yeah. It's not moving.
Sir, can you stop the full screen and then try again, sir?
I think sir has to stop.
Oh, it's got frozen again.
So we can stop and again once again you can restart.
Sir, we can go back to, okay, sir. Now the slides are visible, sir.
1 second. It's getting frozen again. The slide control is with you, Shanavas?
No, sir.
No, sir.
Do you have?
No, sir, no.
Because I don't have control over the slides.
Whose screen is right now on Zoom?
Yeah, can't you see the screen?
Sir, your screen is there. The presentation is also there. You can make it full screen and then just try to change the slide.
I'm not able to make it full screen. The cursor is not there with me.
Sir, but this is your screen only, right?
Can you take over, Shanavas?
Praveen?
Sir, for that actually someone else should have the presentation with them, sir.
All right.
Sir, I think your laptop got hanged. So what you can do is that you just close the slide now, cross it, and after that again open the presentation so it will move.
Hello?
You're audible, sir, but it's
Yeah.
slides are not moving in the freezing second.
Just come up.
So you can once close the presentation, then restart. I think your laptop got hanged.
The cursor is not functioning.
Your laptop got hanged.
1 second. 1 second. I think it's got hung again. Escape.
Sir, you can press Window plus D button together.
1 second.
Done, sir. Refresh it and try to restart the presentation again. Yes, sir. You can reshare your screen and open the presentation. Then it will work. Sir, can you hear me?
No, sir is currently not online.
Okay, I think he got disconnected.
Riya sir, can you call him?
ഞാൻ വിളിക്കാം. അല്ല റിയാസ് വിളിക്ക് വന്നു.
ഹലോ, ഞാൻ വിളിക്കാം മാഡം.
ഓക്കെ. He must be trying with the other, some other.
Right. Yes.
Yeah, right. Anil, he has joined back.
Okay. Okay, ma'am.
Yes, yes, yes.
Yes.
Oh, that's another issue.
Yes, sir.
Is it
Yes,
got
sir.
now?
Yes,
Yeah.
sir.
It's coming. It's coming.
Yes, sir.
So now it's moving, huh?
Yeah, it's moving. Yeah, okay.
Yes, sir. Yes, sir.
Now, I finished the secondary causes of fatty liver. Is it only a problem in the yes? No, it is in the pain. How do you suspect? This is the important point. Now, this is what we call as acanthosis nigricans. So for all of you who are watching, if you have a child who's got this sign, there is a metabolic syndrome and there is a fatty liver most likely. What are the lab features you will find? Elevated ALT, elevated GGT, sometimes an impaired glucose tolerance and an abnormal lipid profile, but both these are not a must. You can get a fatty liver without there being an abnormal lipid profile. What's the role of ultrasound? Now remember, fat is hyperechoic and the sonologist will compare it with the spleen and the kidney. In a fatty liver, the specificity is 93% and sensitivity is 89%. But for detecting fibrosis, a conventional ultrasound has a very poor sensitivity. But the problem we have is that the sensitivity and specificity decreases as the BMI increases. So if you have a child who's grossly overweight, you will find that the sensitivity on ultrasound is much lower. And this is a big drawback with ultrasound. That must be made very clear to the patients when we do this. So a mildly obese child, it's easy to pick up a fatty liver on an ultrasound. A morbidly obese child, because of the presence of so much of subcutaneous fat, the sonologist may not be able to appreciate it. What is ultrasound elastography is what we call as fibroscan, and what is used is this transient elastography. That is what is available in India, and it's got a very high predictivity for fibrosis. So if a fibroscan is available and your ultrasound is showing a fatty liver, ideal that you should get a fibroscan done to see what the extent of the fibrosis is, because that tells you the differentiation between steatohepatitis with fibrosis and a steatohepatitis without fibrosis. This, from the diagram that I showed you earlier, is very important for you for prognostication and management. What's the role of CT scan? There is no role for CT scan in view of radiation. What's the role of MRI scan? Got a very high specificity, but remember, most MRI scans in our country, the centers don't have the software for fat measurement. So unless they have the software to do fat assessment and measurement, do not do an MRI scan. It is a waste. What's the role of liver biopsy? It's the gold standard, but no parent will allow you to do an invasive procedure like a liver biopsy for a fatty liver. And we do not have criteria defined for children, though these are the criteria for adults. But the important thing is that you can differentiate steatohepatitis from a steatohepatosis if you can do a liver biopsy. There are arguments in favor and arguments against. But basically, it says that why should you do an invasive procedure for a disease or a problem which has no standard therapy and the prognosis is very good. Therefore, this is a controversy. Most parents will not allow you to do a biopsy. So I would suggest that we manage with an ultrasound, fibroscan, and monitor them with an ALT and a GGT on liver enzyme studies. Are there any predictive markers? These are the three. This is the predictive marker that is considered the best. It's called PNF5. That is Pediatric NAFLD Fibrosis Index. And they use three markers. One is the age, the waist circumference, and the triglyceride levels. And it gets this a score that is calculated, and you can predict fibrosis of the liver in these children. This is widely used. It's got a good positive predictive value, but negative predictive value is not very much. ELF score is much more difficult to do and not useful in practice. People have also tried to combine these two. That means both the PNFI and the ELFI to give you a high positive predictive accuracy. Results are good, but not satisfactory. So in our setup, I think we should make a diagnosis of fatty liver based on those three things that I said: ultrasound, fibroscan, and liver enzymes, and monitor progress with the PNFI, that is the age, waist circumference, and triglyceride levels. What are the predictors in PFLD? Predictors of progression is the persistence of insulin resistance and obesity. Predictors of fibrosis are the three things that I told you a little while earlier: age, triglyceride, and the high waist circumference. This is the high waist circumference that we are talking about. If you want to do a biomarker, the only one that is available and widely used is the IL-6, which is used only for research. Practically, it has got very little role. Now, this is an important slide that I'm putting up. How early can pediatric fatty liver disease start? I told you earlier that steatohepatosis is not seen in young children below 3. But does it mean that fatty liver starts only after the age of 3 years? Now, this is a study published 7 years ago. This gentleman has taken babies of 13 normal mothers versus 12 obese mothers who had gestational diabetes. And he did an MRI on all of them at the age somewhere between 15 to 20 days of age. And he found that these 12 obese babies of obese mothers had 68% more fat compared to the normal babies. They have also published a study which states that there is increased abdominal adipose tissue and steatosis in babies who are born to mothers who have a higher BMI than normal. This is again another study which was published 5 years ago, where they have taken stillborn babies of diabetic mothers and found on autopsy that all these babies who died had much more fat in them compared to babies who had died of normal weight and normal fat. And that brings us to this question of fetal epigenetic program. In other words, does the intrauterine environment program your subsequent development of fatty liver and a metabolic liver disease? There is increasing evidence to suggest that the intrauterine environment modifies your genetic programming. That is called epigenetic program. That means the environment modifying genetic potential. And this is an important concept which now is coming up in various diseases. Earlier we thought that genetics could not be modified. Now we know no environment, particularly intrauterine environment with micronutrients and B12, etc., and obviously now fat can modify that program. How do you manage PFLD? The one and only thing to do is to do sustainable lifestyle changes. All these words are important. Sustainable lifestyle changes. And this particular study on 90 children who had 20% weight reduction in 12 months showed 68% had a lower ALT. Similarly, another study showed 65% improved ALT provided they did dieting and 1 hour of exercising every day. But remember, I told you sudden weight loss can lead to progression of NASH. So there must not be a sudden weight loss in these children. No to alcohol may not be relevant in our setup, but I'm sure it will soon become relevant. Avoid hepatotoxic drug. But these are the two questions that we don't have the answers for. How much weight should they lose? And in how long a time should they lose weight? Very easy to talk about lifestyle changes. Last for a few months, but very difficult to enforce on a long term, unless it is an influence of society and school and everybody concerned. to make a general lifestyle change in all children in our schools and in our society rather than in individual homes. What's the diet that you should be giving them? Carbohydrates with low glycemic index. Saturated fat should be less than 10%, very important. And most importantly, restrict high fructose beverages and refined sugars. This may just be a coincidence, but increased fructose consumption in the world, which has occurred in the last 30 years, in the form of soft drinks and sugars and ready-made foods, has coincided with high rates of metabolic syndrome and fatty liver in the world in the last 30 years. In other words, it may be just a chance, but there is a lot of evidence now to suggest that the implicated agent in this is fructose, because fructose is metabolized exclusively in the liver and it gets shunted into the fat forming pathway in the liver and it causes rising of the triglyceride levels in the blood. Not only that, fructose seems to be able to alter the expression of genes which causes fatty liver. In other words, liver and fructose are not very good friends. They basically have an antagonistic relationship, that fructose does lots more damage to the liver than we initially thought. So one way of controlling this metabolic syndrome, fatty liver in the world, will be to cut down the consumption of fructose, which has gone magnified in the last 10 or 20 years. Pharmacological intervention, metformin has been tried, but current guidelines say they have no role at all. Pioglitazone has shown promising results in adults, nothing in children, so the recommendation is no. Vitamin E, like many other things, showed a lot of promise initially, but current guidelines do not recommend these high doses of vitamin E for fear that there may be serious side effects if you use high doses of vitamin E. UDCA, small studies have been done. The ALT seems to decline, but the fat in the ultrasound on the liver has not shown any decline. So it seems to be a direct effect on the hepatocytes rather than on the process of fatty liver that the UDCA is changing. And therefore, our current studies do not recommend UDCA as a treatment of fatty liver. Probiotics, as with all studies on probiotics, it still remains a promising area of research. Nothing much convincing to say. So as of now, small studies here and say, company recommended to say that it's good for fatty liver and metabolic syndrome. My take on it is, as of now, nothing has been proven. Statins, recommended in adults. In children, we recommend it only to correct dyslipidemia. If a child has dyslipidemia as part of his metabolic syndrome, you can use statins, but not as a treatment for fatty liver or for the disease as such. What's the role of bariatric surgery? Highly recommended in adults, but this is the Cochrane database which says that as of now, the role of bariatric surgery in children and adolescents is unconvincing. No role as of now for fatty liver. This is the current guidelines. It says while bariatric surgery is not contraindicated in otherwise eligible obese patients, it is not an established option for treatment for fatty liver per se. So you can use it if there are other indications, but not for the treatment of fatty liver. So what's the carry-home message I have for you? Fatty liver disease is a spectrum starting from fatty liver steatosis to cirrhosis. That spectrum takes many decades. So we are not likely to see cirrhosis, but we are going to have a lot of the adult gastroenterologists seeing young adults with unexplained cirrhosis, which has its origins in childhood. Always rule out other causes. Metabolic, I gave you a few, hepatitis, malnutrition, HIV, but without ruling secondary causes, you must not call it as NAFLD or PFLD. The setting is an obese adolescent with acanthosis. Please look for acanthosis. Parents will attribute it to the new gold chain or new some synthetic chain that they put. No. Acanthosis is a sign of metabolic syndrome and it is not a form of allergy. Hepatomegaly and increased ALT. Ultrasound elastography for diagnosis. If you have the software, use an MRI to quantitate fat. Histology is the gold standard, but practically not done. Weight loss with long-term diet changes and particular attention to fructose is the key to good management. Drug therapy in any form is currently not recommended in children. Thank you very much. I'll take any questions if you.
Thank you very much, sir, for your very crisp presentation with a lot of take-home messages, of which the two important ones you have already mentioned is you should discover fatty liver early so that it will not progress to other stages. And also you should have a sustainable lifestyle modification. So regarding the questions, is the PM-induced NASH or fatty liver will progress just like that of obesity-induced NASH?
Give me the question again, sir.
You said there is one cause of fatty liver is malnutrition, kwashiorkor.
Yes.
And the other is obesity. Will it go in progress?
Both
just
will disappear. Both will disappear. With treatment of malnutrition, fatty liver will go. With treatment of obesity, fatty liver will go, provided fibrosis or cirrhosis has not set in both situations. Cirrhosis is what we now call as uncontrolled fibrogenesis. Normally, there is no fibrous tissue in the liver. What puts on that switch of fibrogenesis is what we don't know. If you can find a drug that stops fibrogenesis, that will be a miracle. You can drink 35 years of your life and then you find there's fibrous tissue in the liver, you start that drug, you will be safe. We don't have a drug. It's like a switch that once put on cannot be put off. Whether it is in alcohol, whether it is in obesity, whether it is in malnutrition, whatever is the setting, we need to treat it before fibrosis starts. Otherwise, all fatty livers are reversible.
So at what stage we should ask for a fibroscan?
If there is steatohepatitis, you must ask for a fibroscan. That means you have elevated enzymes which are persisting, more than twice normal, not coming down, and there is a metabolic syndrome. You must do a fibroscan.
The question is a general question. Are there any age-related waist circumference standards for children?
Oh, there are standards for children.
Okay, there are no more questions. Thank you very much, sir, for your presentation. Thank you.
Thank you very much.
So thank you, Dr. John Mathai, for that excellent insight to the topic. Apart from our technical hinges, I think, which usually happens with this, and Shanavas for chairing the session. So thank you once again.
Thank you very much.
So let me move on to the next session of the day. It's important that rational investigations in pediatric infectious diseases. I hope Dr. Tanu,
yes.
Are you there? Okay,
yes,
okay.
Can I share my screen, ma'am?
Just okay, right. We all know that a focused, I'm going to chair the session as well. We all know that a focused history and a clinical examination will help you to make a diagnosis in more than 80 to 90% of the cases. What I'm trying to say is that investigations do have a minimal role, and that too we have to be very rational. So for example, timing is important. The serology in the case of dengue fever or enteric fever, etc. If you do it too early, it may become negative. So that means we can't rule out the infections for that. So what are the investigations and what are the timing of the investigations? The common infections that we come across, I think it's going to be dealt with Dr. Tanu Singhal. She is an expert, infectious disease expert, working in the Gokulam and Dhirubhai Ambani Hospital, Mumbai. She took her MD Pediatrics from the prestigious All India Institute of Medical Sciences, and after that MSc Infectious Disease from London School of Hygiene and Tropical Medicine, London, UK. And she has many official positions, that Executive Board Member, Fungal Infection Study and RNDCP, with special interest in infections, especially the COVID, tuberculosis, and more than that, she is also an advisor for antimicrobial resistant and stewardship program of ICMR. I'm extremely happy to welcome Dr. Tanu to our midst, and to add that she's a very well sought after speaker in any infectious diseases, either national or a CME level. I'm really a fan of yours, Tanu. And after hearing you in many of the infectious disease conferences only, I tried to contact you. Even though she did not know me personally, she readily agreed to come as a faculty for this CME. I'm extremely happy to welcome to you. Over to you then.
Thank you, Dr. Lalitha, and thank you for inviting me here. And I hope that my presentation will be helpful to people in their day-to-day practice. So, if I can share my screen, yeah.
Yeah, you share.
Yes. So, is my screen visible?
Yes, you're visible and you're audible.
Okay. So basically, I'm going to talk about rational investigations in pediatric infectious diseases, and I'm doing this in the form of a case scenario. So, unfortunately, we don't have this option of, people responding. So when I ask a question, I would just like the viewers to think in their mind, what would they have done in the setting of this particular problem, what investigations they would have ordered, and then we will try and discuss that what could be right approach. And while we all talk so much about rational antimicrobial therapy, we don't talk about rational investigations. And I think that is also very important. And I really congratulate Dr. Lalitha to think of this topic, because this is the first time I'm doing a topic like this. So I hope I'll be able to do it well. So let us come to the first scenario, which is a very common in our clinical practice. Like you have this 4-year-old who comes who's a previously healthy child who comes with history of fever of 36 hours duration. And the fever is quite high, reaching 101, 102, for which the parents give antipyretics, and the child is well in the interfebrile period. And there is no focus and there is no sick contact in the family, and the physical examination is normal. There are no red flag signs on physical examination. So this is what we would call as a fever without focus, where, people would have, issue of whether they could be dealing with a serious bacterial infection. So my question to the audience would be, and I would like to answer this in your mind, that in this setting, what investigations will you do? Will you do a complete blood count here? Will you do a CRP? Will you do a malarial parasite? Or will you check for a urine routine? Or would you probably hold back investigations at this point in time? So if we think of this setting, it is most likely a kind of viral infection that we are dealing with, because it is of abrupt onset. And also the fact is that it has not shown a focus, but many times in many viral infections like influenza or others, the focus may come on the 2nd or 3rd day. The fact that the child is well in the interfebrile period further tells us that it is a viral infection. So in this situation, what we could possibly do, or means what I generally do in my practice, is to just allay the anxiety of parents, continue the antipyretics, and counsel them that if the fever does not show signs of settling by the 3rd day, and if there is no focus which has developed, then in that situation, we would go for investigations. So probably I would in this setting not do any investigation, because this child is 4 years. So he's, not less than 36 months old, where you're really worried about serious bacterial infections. And we know many of these patients with flu throw a focus on the 2nd or 3rd day. So here we could probably hold on investigations till at least 48 to 72 hours have passed by. And yes, if after 72 hours we find that the patient is not getting better, that is when you could order investigations. You would, but even before that, you would like to examine the child again, because many times a focus would have developed, which you could pick up on clinical examination, and then you would not need to do investigations at all. There would be, however, some situations where you may have to, they may have exceptions to this rule, because you have a child who's very febrile, or you have parents who are very anxious. So definitely an antibiotic is not in order, but you could just ask for a complete blood count, because that could also tell you what you're possibly dealing with. And if you see that you have a count where you have lymphocytes or monocytes, That is quite helpful to look at the differential. And if you look at the peripheral smear and you see reactive lymphocytes, then you know that you're dealing with a viral infection and you would just observe the child. So let us come to a second situation. A 7-year-old comes with high fever and sore throat of 2 days duration, and the patient does not have any cold or cough. The tonsils are enlarged with some exudates and the cervical nodes are tender. So this is what looks like a streptococcal sore throat. So in this situation, what investigations would you do? Would you send for a throat swab culture for group A beta hemolytic strep? Or would you like to do a rapid antigen test? Or would you do no investigations? So again, if you look at this case, you could use this Centaur score or a clinical decision rule. And if you look at this patient, you find that this patient's total score is 5 because there is no cough. The cervical nodes are tender. The temperature, of course, I didn't mention, but it is 101. You have tonsillar exudates and you have an age between 3 to 14 years. So the patient score is 5. It means that the likelihood of this being a streptococcal sore throat is very, very high. So in this situation, you actually don't need to do any investigations. You can simply start amoxicillin empirically. On the other hand, where you have situations where this score is low, I mean, you know, like you have a score of 0 or you have a score of -1, then also you don't need to do any investigations because these are patients who are not likely to have a beta hemolytic strep. And if you do the tests, you may pick a commensal because this streptococcus is also present as a commensal in your throat in 30% of the population, and you may actually wrongly treat the patient with antibiotics. So the role of investigations here is actually in patients who fall in the intermediate category, where their decision whether or not to use antibiotics may depend on this test. And the antigen test is actually a good test because it is very cheap. It costs just about 100 rupees. And you get a result very fast. However, a negative antigen test sometimes may need a culture. The second thing which you can also do is that you can ask the lab to do a culture and no sensitivity testing, because you know that group A beta hemolytic strep is universally sensitive to amoxicillin. So you don't really need to do the sensitivity. So this is a situation where, you know, the need for investigation actually depends on the likelihood of the disease. And therefore, if the disease is highly likely, then doing investigations is not beneficial, because let us say your RADT would come negative. Would you hold back antibiotics in this patient? No. Another thing which helps you in day-to-day practice is actually not an investigation, but looking at the same patient after 1 or 2 days. Because when you see a patient on the first or second day, you may not see the telltale signs. So at that time, you can give antipyretics. And if you call the patient after a day or 2, you may actually see the exudates and you are more certain of the diagnosis. And we know that we can start antibiotics up to 9 days from the day of onset of symptoms. And you would still prevent rheumatic fever. But an important thing is that if you do start antibiotics, then give the right drug and give it for the right time, which is about 10 days. There is another scenario where you might need investigations in a patient presenting like this. And that is if your patient does not respond to antibiotics and has other unusual features, like has basically hepatosplenomegaly or generalized lymphadenopathy. So in that situation, you might consider the diagnosis of infectious mononucleosis. And in that situation, you should do a complete blood count with peripheral smear. You should do a EBV VCA IgM, because then that will give you the diagnosis and you will not unnecessarily keep changing antibiotics for this patient who would not respond to antibiotic therapy. Now, let us come to a third scenario, which is very common in clinical practice, that a 1-year-old child comes to you with severe watery diarrhea and some dehydration, and he's admitted. And when you take a vaccination history, you find that this patient has actually received the rotavirus vaccine when he was 6 weeks and 10 weeks old. So the question here would be that, would you like to do any investigations? Of course, you may, I'm talking about investigations to establish the etiology of diarrhea. You may want to do electrolyte, you may want to do a bicarb to just see if there is dyselectrolytemia or acidosis. But for etiology, would you like to do a stool routine here? Would you do a stool culture, or would you do a stool rotavirus antigen? So in your mind, which investigation would you ask for? So actually speaking, you may not need an investigation because this age is where you have viral diarrhea, and this watery diarrhea with some dehydration, if it is associated with vomiting and there is no blood in the stool, is what viral diarrhea, which can be due to rotavirus, it can be due to novovirus, it can be due to some other virus as well, and you can just treat symptomatically. But if you were to do an investigation, then a stool rotavirus antigen, I think, is a good test to do here, because if it is positive, then you know that this diarrhea will take time to resolve and you don't need to use antibiotics. Because many times these patients are admitted, they continue to have a high purge rate and the parents are very anxious, and you are also pushed to the brink, and you feel like giving antibiotics. So if you have a report saying that rotavirus is positive, then you will definitely hold back antibiotics. A stool routine is really not helpful in this setting because there is no visible blood in the stool. And even if you find 8 to 10 pus cells in the stool, which is seen in viral diarrheas, you will not take the decision to use antibiotics. Similarly, a stool culture is not useful in this setting when you're not thinking of shigellosis. A stool culture would be of use in a patient where you're thinking, who has bloody diarrhea, where you're thinking of shigellosis and you want to know the antimicrobial susceptibility of the isolate, because there's a lot of drug resistance happening in Shigella. So if at all you want to do a test for etiology, you could do a stool rotavirus antigen. There is another test which is nowadays available called as the multiplex PCR, where you pick up a lot of GI pathogens, including viruses, including Shigella, E. coli, but it is a very expensive test, and therefore it is not really recommended in day-to-day practice. Now, let us come to another situation. So, for example, I'm talking about Mumbai, where there is a monsoon season is there, and there is an ongoing dengue epidemic. You have a 10-year-old with fever for 3 days, which is sudden onset, high grade. And when you examine this child, physically, the child is normal, the pulse and BP, everything is normal. So in this setting, obviously, you are going to do investigations. So my question is that what investigations will you do in this patient? Because your differentials are dengue, malaria, maybe enteric fever, etc. So would you do all the investigations at one go? Would you do, of course, we will do a CBC in this patient, but would you do a malarial parasite smear, which most people would say yes? Would you do an NS1 antigen ELISA? And most people would say yes, because dengue is first on the cards given the epidemiology. Would you do a rapid dengue test like the immunochromatographic test with tests for NS1, IgM and IgG? Will you do a typhi.IgM? Will you send a blood culture up front? And will you do a CRP? So these are the usual basket of tests which we do in a patient who comes with a monsoon-related febrile illness. But in this patient, I feel that if you want to use your investigations rationally, you can just start with blood count, malarial parasite, and an NS1 antigen test. Now, why not do a blood culture? Because first the onset is sudden, and you are seeing more dengue as compared to enteric fever, and blood culture is an expensive investigation. So it would be probably a second line test here, because your first possibility is not enteric fever. Typhi.IgM is not a good test at all, and it should not be done because you see a lot of false positives. And if you have a patient who has both an NS1 and a typhi.IgM positive, many of these patients are treated with both antibiotics and supportive therapy, which is not indicated. A CRP is really useful in the setting where you are thinking of, a bacterial infection like typhoid. So even here, you may actually do away with it. So in the beginning, you would do a blood count, malarial parasite, and an NS1 antigen. Now, what about the immunochromatographic test? The immunochromatographic test, the advantage is that one, it has a very good turnaround time. You can get the result in an hour. The problem with the test is that the sensitivity is lower. So you may have dengue and yet your test become negative. But and the government is not approved of this test, but it is a good test to do if you want a quick diagnosis, because if you have a NS1 which is positive on the immunochromatographic test in a setting of dengue, then you are more or less certain of the diagnosis. So therefore, and in some places, your NS1 antigen ELISA comes after 1 or 2 days. The other important thing to understand here is that if your patient comes to you on day 4 or day 5 with a dengue-like illness, then apart from doing an NS1 antigen, you should ask for an IgM and IgG as well, because many of these patients, especially if they are secondary dengue, will lose their NS1, and therefore if you just do an NS1, you might miss the diagnosis. So I think in this situation, you can save on money by just asking for these tests. And if these tests come negative, then of course you can go ahead and do other tests for investigating this patient. Now, contrast this with this case. This is a patient, this is an 8-year-old girl who has fever for 6 days. And she has low-grade fever in the beginning, and then there's high-grade fever. She has been on co-amoxiclav for 3 days with no improvement. And she has a toxic look and coated tongue. So this is what, typhoid fever or paratyphoid fever would present with classically. So here the question comes that what investigations are you going to do in this patient? And I have put forward these investigations here: a blood count, malarial parasite, blood culture, CRP, typhi.IgM, and Vidal. And you can again think in your mind that what tests would you ask for in this patient? So as per me, I think these are the 4 tests which we can do here. Of course, you need to do a CBC to know, to rule out other possibilities. If you see a normal or a low white cell count with predominant neutrophils and absent eosinophils and a borderline platelet count, that would make you think more of typhoid and paratyphoid fever. Malarial parasite, we all tend to do reflexly, because if you miss malaria, then that's a sad thing, and it's not a very expensive test either. Blood culture is the most important test here, because that is the test which will give you an etiologic diagnosis. And some people would say that this patient has already been on antibiotics for 3 days, so should we really invest in a blood culture? And the answer is that Salmonella is not a very fastidious organism, not like pneumococcus or Hib, where the culture can become negative after 1 or 2 days of antibiotics. So, and Salmonella, you need at least 100 milligrams per kg per day of ampicillin. So this patient would have been on a lower dose, so you can still get a positive culture. So blood culture is an important test. And again, CRP in this situation may also be a good test to do, because not so much in this patient, but other patients who come to you with 4 to 5 days of fever, a CRP helps in distinguishing between viral and bacterial infections. And in most patients with enteric fever, the CRP is high. And also another advantage of doing the CRP is that you can track the infection. So if you have a baseline CRP and you start the patient on antibiotics for enteric fever, and the patient's fever is not coming down in 3 to 4 days, but the CRP is coming down, then you know that you are doing the right thing. Again, as I said, typhi.IgM is not a good test because it has high rate of false positives. And Vidal is definitely not indicated here because this is still the first 7 days of the illness. A Vidal we shouldn't do, but if at all we do, we should do it in patients who come to you with more than 1 week of fever, who have been on antibiotics, where the chances of a blood culture coming positive is less. Another test which may be useful in this setting, which I'm not kind of listed in this list, but I do it in clinical practice, is an ultrasound of the abdomen. And if you have a good ultrasound person, by day 5, most patients with enteric fever have a splenomegaly. On the ultrasound, they have terminal ileal thickening, and they also have reactive mesenteric nodes. So that also tends to help you in making a diagnosis, especially in patients who have been on antibiotics for some time, where the chances of getting a positive culture become low. So that may be another investigation which you can add to your portfolio. Now let us come to this other setting of a respiratory tract infection. You have a 5-year-old who comes with fever and cough for 3 days. And this child is having mild tachypnea, but there are no recessions. The saturation is 97%. Please remember to check saturations in all children who come to you in the OPD, because it's like a 5th vital sign. They are right basal Krebs. And you make a diagnosis of pneumonia here, and you plan to treat the patient on an outpatient basis. So the question here is that which investigations? Now, if I had done this talk 1 year ago, I would not have put COVID RT-PCR in this. But now any patient who comes to you with a influenza-like illness, or has fever and cough, or has features of a lower respiratory tract infection, whether or not there is a contact history, we would have to do a COVID RT-PCR. But would you actually do a CBC, chest X-ray, blood culture, and CRP here in a patient with clinical diagnosis of pneumonia who you're going to treat on an outpatient basis? And the answer is probably no. Because for outpatient management of pneumonia, you really don't need to do these investigations. And you could, because again, if you do an X-ray, it means radiating the child, and it also, there's a lot of inter-observer variation in interpretation of X-ray. The chances of a blood culture coming positive in this patient with a mild pneumonia are low, so it's not indicated. A CBC, CRP, again, in a patient with a mild pneumonia may or may not help you. So actually speaking, in this patient, in the current day and age, all you would do is a COVID RT-PCR, and you would start this patient on empiric antibiotics, and probably the antibiotic of choice here would be just amoxicillin. And if this patient does not get better in a day or two and has worsening distress, that is a point in time where you would hospitalize the child, and then you would go ahead and investigate this child doing all the other tests which we just discussed. Now let us come to another common scenario, which is basically a 4-year-old who has fever and cough of 2 weeks duration. And this patient has basically been on antibiotics and has not got better. There is weight loss and there is a contact with TB present. So this is a patient who meets the criteria of a possible TB as per the RNTCP and the IAP guidelines. So in this patient, what investigations would you do? So I have not really talked about CBC, etc., because I mean, you can do them, but they really, CBC or ESR is of no benefit, but you could do a complete blood count if you wanted to, but again, that is not really going to help you in the diagnosis. So the investigations which would help you in making a diagnosis would, and I've listed some of them: a chest X-ray, a tuberculin skin test, or an IGRA, and a gastric lavage for smear, TB culture, and CB-NAT. So this is a patient in whom the cough is non-productive, and you know a 4-year-old is not able to bring out any sputum. So you can again think in your mind what would be the test which you would do. And again, in this patient, and of course I've also put a CT chest here. But again, if you look at it, in this patient, the most important investigations are actually a chest X-ray and a gastric lavage for smear, TB culture, and CB-NAT. Now, why is tuberculin skin test not there? Because tuberculin skin test, one is that the proper strength tuberculin is not available. You need to do it with 1 or 2 TU, and you have only 5 and 10 TU available. And second is a tuberculin skin test does not differentiate between infection and disease. So a positive TST does not confirm the diagnosis of TB, and negative TST does not rule it out. Similarly, IGRA, which is a more fancy kind of TST, again, tends to pick up latent infection and does not differentiate infection from disease. Many people use the IGRA as a for its negative predictive value, because they feel that if in a patient where they have been investigating for TB and none of the investigations have helped, and if the IGRA comes negative, they can rule out TB. But that's not true, because studies in the Indian setting have shown that only 70 to 80% of children with culture-proven TB have actually a positive IGRA. So again, IGRA is not useful. So you would definitely do a chest X-ray here, because if your chest X-ray shows you some of the classic changes, like either a hilar adenopathy or a cavitary consolidation or miliary mottling, you know you're dealing with TB. And also you would do a gastric lavage for AFB smear and CB-NAT definitely. And if you are working in the private sector, you would also send it for TB midget culture, because we know that the sensitivity of the midget culture is more than that of the CB-NAT. And if you have a CB-NAT, you can do an either expert or you can do an expert ultra. And expert ultra is supposed to be more sensitive as compared to the conventional expert. Now, what would be the role of CT chest here? So suppose you have a child where you do a chest X-ray, which is showing some infiltrates, and your gastric lavage is negative. Then how do you do? So one option is that if it is like TB, you start treatment empirically for TB as a clinically diagnosed TB. The other thing which you can do is that you can probably refer the patient to a higher center where they can do a bronchoscopic lavage. And the third thing which you can do in this setting is to do a CT chest, because Sometimes in a CT chest, you might find changes which are more pathognomonic of TB, like you may see a cavitary consolidation, which is not obvious on the chest X-ray, or you may see necrotic mediastinal nodes, which will again make the diagnosis of TB more likely. But we must understand that the CT chest has to be done with care, and because it has radiation risk and it is expensive. On the other hand, if you are dealing with a patient with a pyrexia of unknown origin for 2 or 3 weeks, where there is no respiratory sign or symptom and the chest X-ray is normal, you would do a CT chest, because many of these patients have actually extrapulmonary TB with necrotic nodes which cannot be picked up on the chest X-ray. And in these patients, their gastric lavage is also negative because there are no parenchymal lesions. So remember to understand the value of various investigations when you are investigating a child for suspected TB. Now let us come to another more complex case of respiratory tract infection, which is different from the case which I talked about earlier. This is a 9-year-old child who has fever, cough of 5 days duration, and he is breathless since 2 days. And on admission, he has a saturation of 92%, he has a respiratory rate of 40, and he has suprasternal, intercostal, and subcostal recessions. And of course, they are crept on physical examination. So this patient actually meets the criteria of very severe pneumonia, and the patient is admitted into the ICU. Now, in this patient, it's different from the earlier patient. So what investigations would you like to do in this patient? So obviously, this is a patient where you would do a COVID RT-PCR in the current scenario of COVID, because rarely you can have children which come to you with severe COVID. You would definitely do a chest X-ray here, because that would tell you what is the extent of disease, and it may also help you in differentiating between a viral and bacterial pneumonia. You would do a complete blood count here, because again, that may help you, not always, but if you find that there is severe leukocytosis with polymorph predominance, then and a high CRP, the chances of a bacterial infection are higher. And you would do a blood culture, because blood culture is recommended in patients with severe pneumonia who are admitted, because that is probably the only way you may make a diagnosis of pneumococcal pneumonia. So I would say that these 5 investigations one would do. Now, after that, it's basically optional, because our treatment of pneumonia is syndromic, because you know that depending on the age of the child, you can predict what are the etiologic organisms. So in a 9-year-old child who comes to you with a pneumonia, your likely organisms are pneumococcus, mycoplasma, and the various viruses. So your empiric therapy would include beta-lactam with a macrolide if the patient is very sick, and with or without oseltamivir, depending on what is the ongoing flu epidemiology. So if this patient comes to you during a flu outbreak, and if you find that the patient has bilateral infiltrates on the X-ray, then you would probably add oseltamivir also in the empiric regime. And of course, we are not discussing COVID here, but if your COVID RT-PCR is positive, then you might even consider the use of remdesivir in this patient. Now, there are other investigations also which are available to us to make an etiologic diagnosis of pneumonia, and these investigations are expensive. So among these are the multiplex PCR in the throat swab. So you have a biofire film array panel, which is it can detect 22 pathogens in an upper respiratory specimen. So it can pick up the influenza viruses, the parainfluenza, the RSV, adenovirus, and the other 4 coronaviruses which are there in circulation apart from the COVID. It can also pick up mycoplasma, chlamydia, and this Bordetella pertussis. So these are the pathogens which it can pick up. So in a patient where you have the you have the logistics, you can do this, but remember that this is in the upper respiratory specimen, so you cannot always predict what you find in the upper respiratory will actually reflect what is going on in the lungs, but this is available to you. And now you have basically the multiplex PCR available, which also incorporates the COVID in it. So you have a COVID apart from the other viruses also. Then you have an influenza PCR in the throat swab. And if you are during an ongoing flu outbreak, you should send this, because one, it is cheaper than a multiplex PCR. And on the TrueNat platform, which we are commonly using for diagnosis of COVID, an influenza PCR costs less than 1,000 rupees. So if you make a diagnosis of influenza, then it is important for reporting also. And also, you are not going to go big on the antibiotics, and you are going to treat this patient with oseltamivir and supportive care. So in that sense, influenza PCR is beneficial. And what about Mycoplasma IgM? So many of these patients may actually have a atypical pneumonia. If you have a patient who has come with this kind of pneumonia, who has basically abnormal liver enzymes, has a rash, has dropping hemoglobin, has a pleural effusion, then you can think of mycoplasma. And how do you confirm the diagnosis of mycoplasma? One is, of course, you can do a multiplex PCR in the throat swab because it will pick up mycoplasma. You can do cold agglutinin and you can do mycoplasma IgM. However, in a patient who has just symptoms of 5 to 7 days, your mycoplasma IgM may come falsely negative as well. But that is another test which you can do to confirm the etiologic diagnosis. But remember that these tests are optional and they are not absolutely essential. Let us come to another complex scenario. And this is a 6-year-old who has fever, vomiting and headache for 3 days and who has received comoxiclav, and he has neck stiffness now. So obviously we are dealing with probably a meningitis, which could be either viral or bacterial. So which investigations would you do? CBC, CRP, blood culture, CT head, and CSF examination. And amongst the CSF, what tests would you send for? So again, in this patient, a CBC is important because it may help you to differentiate between viral and bacterial meningitis. A CRP is important. And if you can do it, a procalcitonin is also helpful because a negative procalcitonin has a high negative predictive value for bacterial meningitis. A blood culture is very important because some of these patients, if there is delay in doing an LP, you may give the first dose of the antibiotic and your LP may become negative. And this patient's already been on antibiotics earlier. So a blood culture should also be sent. CT head is not needed in all patients who come to you with a bacterial meningitis, suspected bacterial meningitis, unless they have an altered sensorium or they have clinical signs of raised ICP. So if the child doesn't have these, you can go ahead and do a lumbar puncture without doing a CT head. And of course, you will do a CSF examination and you will send a cell count. You will do a sugar protein, gram stain and aerobic culture because these are the most important tests which are available to make a diagnosis of bacterial meningitis or aseptic meningitis. But apart from that, you have also this film-array meningoencephalitis panel, which is basically, again, it tests for 14 pathogens. So it picks up pneumococcus, Hib, meningococcus, listeria, group B strep, E. coli, and also it picks up viruses like HSV1, HSV2, picks up CMV, picks up HHV6, it picks up enterovirus, it picks up parvovirus, and it also picks up cryptococcus. So this is a serious infection, and if you have an etiologic diagnosis, it helps you in planning out your treatment, and maybe the cost of the test is offset by the cost of treatment. However, this is a patient with acute meningitis who's previously healthy, so there's really no point in doing a cryptococcal antigen test, and you should not ask for a CB-NAT for TB because you're not thinking of TBM over here. However, if you find a picture in the CSF which is not fitting in with bacterial meningitis, which is not fitting in with viral meningitis, your film array panel is negative, and you have a history of prodromal symptoms in the patient before, then you might want to do a test for TB. And that is why it is also always useful when you collect the CSF, you keep one sample extra so that depending on the results of your preliminary investigations, you can ask for other investigations needed and you don't have to do another lumbar puncture for the child. And then coming to the last, situation, which is mainly a situation which is faced by intensivists, and I hope there are some intensivists in the audience, which you have basically a child who has stayed in the pediatric intensive care unit for a long time, who has a central line, who has an indwelling Foley's catheter, who is on mechanical ventilator, and he develops new onset fever with mild drop in the blood pressure. However, the oxygen requirement remains the same and the endotracheal secretions are still scanty. So in this patient with the new onset fever in a PICU where you're thinking of a nosocomial infection, what investigations would you do? So you have a lot of tests which are available to you, but basically what you would want to do is a blood count, CRP and a procalcitonin, because a negative procalcitonin has good negative predictive value of serious sepsis. And you would send 2 sets of blood cultures. That is very, very important, because in community acquired infection, you can send 1 set of blood culture, but in a patient who has a central line, you should send 2 sets of blood cultures from the line and peripheral venipuncture. Such patients, you should not send endotracheal secretion cultures, because you are not thinking of a ventilator-associated pneumonia. So you would just pick up colonizers there. And routine urine cultures are really also not that important, because urinary tract infection is not a common infection in pediatric intensive care patients, and especially if they have an indwelling catheter. But so that is why your clinical diagnosis would be a central line associated bloodstream infection, and therefore your investigations would be directed towards that. So I think with these scenarios, I just wanted to summarize by saying that why we can treat patients, like Dr. Lalitha said in the beginning, that you can make your diagnosis on the basis of history and physical examination most of the times. And you can treat patients using a syndromic approach. Making an etiologic diagnosis has its rewards. And this is exactly the same situation like what Dr. Kasi referred in his presentation, that, when you look at the WHO guidelines or the Government of India guidelines for management of infectious diseases, it's basically a syndromic approach where there is not much emphasis on investigations. So you treat a child with diarrhea without any tests. You can treat a child with pneumonia with no tests except maybe a chest x-ray and the proper antibiotics, etc. But when you are dealing with an individual child in your practice, then you can invest in investigations to make an etiologic diagnosis. But it doesn't mean that you are trigger happy with your investigations. You need to have a rational approach like you do in prescribing antibiotics. So for example, the first case where a child is just having fever for 24 to 36 hours is not toxic. You don't really need to do any kind of investigations. Similarly, where you have a very strong clinical diagnosis like a streptococcal sore throat, you don't need to do investigations. In a patient who has come to you with what looks like enteric fever, you do the right tests. You don't do typhoid or IgM, and you don't do your Vidal test. And similarly, in some patients, like the very sick ones, like for example, a child who comes to you with an acute febrile encephalopathy, you may want to do more investigations than what is just available, so that you are able to give a diagnostic label to the patient. And also, we must understand that we should avoid both over investigations and under investigations. And investing in appropriate investigations is cost effective in the long run. So sending that blood culture in a patient with typhoid fever is always helpful, though it is a test which costs 700 to 800 rupees. But if you have a positive test, then you are sure of the diagnosis, and then you don't need to do more investigations later when the patient's fever is not getting better. I think with that, I would like to stop my presentation and take any questions, if there are any.
Thank you. Thank you, Dr. Tanu, for that fabulous presentation with the illustrative case scenarios. I think we are running late by almost half an hour, so I'll take just only one question. A few questions, but most of them are mainly regarding, though you had explained very well, if you think the Vidal as well as the typhoid dot is not going to be that helpful, then what test we do for the typhoid fever and what type?
Always a blood culture, because even if the person, that's why you try and do it in the first week, because the sensitivity is the best. And even if you have a patient coming in the second week, you can still do a blood culture. So I think it would be more a blood culture, and in the second week you can do a Vidal if your blood culture is negative. And I think an ultrasound abdomen helps, because sometimes you pick up the telltale changes of typhoid fever. At least in our practice.
Yeah, for the blood culture, I think you should have adequate, well-equipped microbiological labs everywhere. No? So we can say that if it is in the second week, at least viral helps in some way.
Yes, it helps in some way, and also you can make a clinical diagnosis. So you have a child who's running fever for 6-7 days, who has a normal CBC, who has a high CRP. Then you know it is typhoid, even if your culture is not available, and you start the antibiotic therapy for typhoid. I don't think your Vidal will help you in, changing your therapeutic decision. So if the Vidal is negative, you are not going to give the patient antibiotics. So in that sense, I think it's not so helpful.
Typhoid again, you are not recommending at all. That is another question.
Yes, yes.
Okay. Okay, thank you very much, Dr. Tanu. Because of the time constraints, I'm moving on to the next session. Thank you so much.
Thank you.
So the last session, sorry for keeping you all late. The last session of the day is by Dr. Bala Subramaniam from Chennai, and he's going to talk to us on vitamin D queries on prevention and treatment. He is well known to us because he's almost a speaker in all our Kerala conferences. And welcome, Dr. Bala Subramaniam, to our session. And to chair the session, we have Dr. Elizabeth. I don't think she needs an introduction, but as the formality, she is the retired professor and HOD of the Pediatrics from Government Medical College Trivandrum. And now she is occupying the head of the Department of Pediatrics, Mookambika Medical College, Tamil Nadu. As always, I think even after her retirement, she continues to be very active both in the digital platform as well as the physical platform. Sorry for keeping you late, Elizabeth and Dr. Bala Subramanian. Without wasting much time, I invite Dr. Elizabeth to carry forward the session with by introducing the speaker as well as the topic. Over to you, Elizabeth.
Thank you, Lalita ma'am, for that kind introduction and this opportunity. I thank Gokulam Medical College team as well as IAP Kerala and Trivandrum for this great conference, and the subjects have been handpicked. We can see that. And now we know that vitamin D is a lifestyle related disease, but there are a lot of doubts whether it is a hype or a real truth. And we have none other than Dr. Bala Subramanian S from Kanji Gamagodi Child Trust Hospital to enlighten us on this. And we know that he is a national speaker, academician, very popular in the Kerala platform. And he has been awarded fellowship by IAP, by Royal College, and the Best Teacher Award by the National Board, and the Lifetime Achievement Award by the Dr. MGR University, Medical University, Chennai. And whatnot, Child Trust Hospital has been now recognized as the best children's hospital all over India and perhaps in Asia. And that speaks how much dedicated team is there under the leadership of Dr. S. Bala Subramanian sir. And over to you, sir.
Thank you very much. I'll straight away share the screen.
Okay, sir.
Just a minute.
Okay, sir. Take your time.
Yeah. Sorry, it's taking a minute or two. I thank the organizers, particularly Dr. Kailas, for giving me this opportunity. And I'm sorry, there's some technical issue. 1 minute. Let me share the screen. 1 minute. Just.
Okay, sir.
Just a minute. In spite of all the precaution, these tech things, get into
sometimes. Anyway, thank you, Dr. Tanu. I think meanwhile you can take care of the questions in the chat as you are doing now.
Yeah.
I do not know. 1 minute, but just a minute.
Yeah, it has started.
No, it's not. Yeah, 1 minute. It got snapped. 1 minute.
This being a hot topic, everybody is waiting.
Yeah. Just a minute. Just
for lunch.
just a minute. No.
Sir,
One minute. I'm extremely sorry. There's some issue.
It's okay, sir.
Sir, the presentation is open on your laptop, sir.
No, it's on a desktop. 1 minute. Just a minute. I just do it. No, 1 minute. Let me close and come back. 1 minute.
Okay, so that will be better.
Yeah, I'll close this screen and then come back. 1 minute. I'm extremely sorry. Maybe
It's
you.
okay, sir.
Yeah, just a minute. I'll just leave and come back once more. I'll come back. I think that's the only way I can do it. I'll just leave and come back.
Okay.
Sorry.
Sorry for the unanticipated delay. Please stay back with us because it's going to be a very interesting session, at the same time controversial. We always have queries regarding the vitamin D deficiency treatment, how much dosage, how often, and then prevention also, is it 400 or 800? I think so many queries that we have. So please stay with us. That's it. I also take this opportunity to thank you, Dr. Balachandran, for staying with us all the time and actively interacting. In fact, I forgot to welcome you during my inaugural session. Thank you, Bala.
Ma'am, is there any concluding ceremony that you can do now?
It's only a few just word of thanks after finishing this only. I think this happened with Dr. John Mathai's session also. Some issues are still there.
Even I'm waiting to hear Dr. Balasubramanian.
Screen is, I think sir has shared the screen, right?
Yes.
No.
Yes.
This screen is of sir only. Sir, just open the presentation which you want to take. You are on mute, sir.
Please open the presentation.
See, the other thing which he can do is that he can email the presentation to you and you can share it and he can speak.
Yeah. Now he's opening it. He's opening it. Just a minute. Yeah. Screen share. Stop share. New shareable. New shareable. Yeah.
Right, sir. Now your screen is visible.
Yeah. Now it's opening in the screen.
Right. Yeah.
Yeah. Thank you.
Yeah. So now make it full screen and you can good to go ahead then.
Yeah.
Yeah,
okay.
perfectly fine.
Visible? Yeah, thank you.
Yes, sir. Yes, sir.
Sincere apologies for the delay, technical. Thank you very much for this opportunity. The issues for discussion in this session, as given as queries in prevention and treatment, will be as follows. I'm going to discuss the magnitude of vitamin D deficiency. Is it a real problem? I'm going to talk about definitions where there are a lot of controversies. I'm going to discuss screening and testing. And of course, the controversial area of supplementation, how much, when, whom, etc. And the most debated food and sunlight in relation to vitamin D. And when in terms of treatment, I'm going to talk about clinical manifestations of vitamin D deficiency, what we have personally observed, dosage regimens we follow, calcium supplements, and last but not the least, the most debated extraskeletal benefits. My first query would be, is vitamin D deficiency a pediatric problem of importance? Is it important to talk about vitamin D deficiency? That's the most important question. If you look at the figures about the vitamin D status in India, you will find that we have a very good paper from South, from Andhra Pradesh, from Dr. Harinarayan, where he showed way back in 2008, 62% of female children and around 76% of male children had definite vitamin D deficiency as defined by 25-hydroxy levels less than 20 nanogram way back in 2008. Other centers also have published very similar, probably higher reports in northern India. And if you look at the newborns, the data is variable. There are reports of around 80% from Dr. Balala, 26% in our series, 44% from Dr. Jain. The newborn incidence and the prevalence is slightly less than overall status of children. But what is more disturbing is this study from Delhi, where they studied the children in schools and under 5 also. They found that hypovitaminosis D was present in 77% of children. Surprisingly, 16.4% had rickets in a survey. Most of them had very low levels. And they also found out there was hardly any sunlight exposure. This was way back in 2010. I don't think things have changed now. The next thing, so it is a significant problem. Particularly rickets is a significant problem. Many people are saying that with the onset of COVID pandemic and less exposure to sunlight, you're going to get a huge surge in vitamin D deficiency rickets in children. The next debated point, what is the definition of deficiency? Here, the endocrinologists and the physicians have been arguing and debating what is the best level. In Europe, they give one level. In USA, they give one level. But I'm afraid the most accepted definition based on nanogram per ml has been as follows. Deficiency is defined biochemically if the levels are less than 20 nanograms. Sufficiency is defined as levels above 30. Insufficiency is a confusing term, 21 to 29. And anybody who has a vitamin D level more than 150 nanograms definitely has a risk of toxicity. Of course, the labs might give you in moles, for which you have to convert this into 2.5. It's better to use nanogram rather than moles for definition of vitamin D status. But the most debated question with regard to vitamin D status is the basis of diagnosis of this deficiency based on biochemical levels is valid. And if somebody doesn't have levels above 20, would there be health consequences because of that?
Dr. Bala, can I? Dr. Bala, your screen is not completely visible. It is expanded.
Okay.
So you have, can you?
Now is it okay? Now is it okay?
No, I think you have to make it a little more smaller. Otherwise, more than half of his.
1 minute. No, now for my screen it is full. I don't know. Now, is this screen all right?
Sir, you are using a desktop?
Yes.
I think this is because of the desktop resolution. So some part of the text which is there on your slide, it's getting cut on the Zoom screen. But I think, I don't know, like this, if you want to take it, you can take it.
I'll put it.
Make it full screen now and let's see whether it's.
No, I'll do one thing. I'll just reduce it and then make it full.
Maybe that is better.
Now, is that all right now?
Yeah, it is okay now, sir. It is okay now.
Thank you. So many technical problems.
Yeah.
Okay. The answer for this debate is that over the last few decades, they have linked the status of vitamin D, that is this biochemical level, to a wide range of health condition. Name any disease, starting from diabetes to psychiatric problem. They have tried to connect it. And most societies have upgraded the levels based on the association. I'm afraid that's not correct. The higher cutoff makes us feel that the entire world, including me and you, are deficient in vitamin D. So nobody knows at what level, though most studies link the levels to parathyroid activity, they do not know why only a few develop consequences with low levels and few do not develop. There are many people who have never seen sunshine, who have never consumed fish, but they don't have any deleterious effects of vitamin D. That's a debatable question. The next question is, what are the best dietary sources of vitamin D? If you look at literature, it's all Kerala food, all types of fish. I don't know many of the names: eel, pike, perch, herring, salmon, which I don't eat, egg yolk, tuna, cod liver, egg, liver, beef, butter. Only these things contain vitamin D in some quantity. In fact, even amongst them, salted fish, you have to consume nearly 400 grams every day to get at least 600 units per day. None of us do it. Do Indian children get adequate vitamin D from the diet? I'm afraid data suggests they don't. In fact, here again, Dr. Harinarayan surveyed the diets and published in 2007 and came out with data that we have changed our food habits. We take a lot of junk food. We consume only vegetarian food. Unlike in Kerala, we don't have vitamin D fortified foods like in the West. And we take a lot of high fiber diet, which contains phosphates and phytates, which do not allow vitamin D absorption. So this is the fact in Indian children based on a survey. But then there is an exception to this situation. What is that? It is nothing but the situation in God's own country. Here, surveys have shown wherever there is a fatty food ingestion, where there is a fatty fish ingestion, like in Kerala, salty fish, there is a low frequency of vitamin D deficiency in childhood. In fact, there are public health authorities who are considering that in those areas where fish consumption is very good, you don't have to give vitamin D supplementation. Next question is, okay, vitamin D comes from sunlight. It is there in plenty all over India. Can you not get it from sunlight? And what is the best way to get vitamin D from sunlight? The answer is, you have to do this. This is a picture from Karnataka on the Karnataka New Year Day. The youngsters are playing in sunlight around 12 o'clock with oil on their bodies. This is the best way to get vitamin D. Who does it? Nobody. The facts that we must remember is that the best time to expose our son to get vitamin D is not morning, by the morning walk at 6 o'clock. Nothing will get into our skin. It has to be done between 11 and 3 p.m., the peak of office work. That is where you should go, like this lady, lie down in the beach with everything open and receive sunlight, at least 30 minutes of sunlight, at least 5 days a week. If you do that, maybe you may not require vitamin D supplementation. That too, we are all having dark skin, which doesn't allow, which protects us against skin cancer, but doesn't allow vitamin D to get in. This is a photograph which I had taken about 20 years back from my car, a traffic junction near my hospital. Look at this lady, young woman, helmet, visor, and nowadays mask is also added, fully covered, gloves are there, morning hours, and this woman, she is going to become pregnant. What is going to happen to her infant? This is what we studied. We found in around 2000, several infants came with hypocalcemic seizures. The story was same. All these babies are exclusively breastfed, 2 months, 3 months, middle of the night, they'll come with unprovoked seizures, calcium 6, alkaline phosphatase 2000, phosphorus 2. Story, exclusive breastfeeds, most of them in flats, Marwadis or Muslims with parda, high-class Hindus, vegetarians. That is the story. And we realized that exclusive breastfeeding is a risk factor for vitamin D deficiency. When I first presented this on the conference in Tamil Nadu, all the baby-friendly neonatologists pounced on me, saying that I was criticizing breastfeeding. I never criticized breastfeeding. I said that breastfeeding mother, unless she takes a lot of vitamin D, unless she gives vitamin D drops to the baby, an exclusively breastfed baby is at risk for vitamin D deficiency and hypocalcemic seizures. And now everybody accepts the fact and as everybody has started giving vitamin D supplementation to exclusively breastfed infants. The next question is, after that, everybody became vociferous about vitamin D. And vitamin D tests have increased for anything and everything, febrile seizures, epilepsy, leg pains, psychiatric problems. Everybody started testing vitamin D and everybody's level will be low. So what are the definite scientific indications for doing a vitamin D testing in a child? That's the next question. The myth is that you must screen everybody in the country to pick up occult vitamin D deficiency. That's not correct. If you suspect vitamin D deficiency on clinical grounds, yes, you measure 25 hydroxy D levels and not 125. There's no point in doing only vitamin D testing. You have to test calcium, phosphorus, alkaline phosphatase, and also the parathormone. That's the reality. The US Endocrine Society says there is no point in screening everybody. Population screening is not recommended. So whom do we screen in practice? Not those with body ache, not those with Bolex. Those dark-skinned infants who live at a higher altitude, Kodaikanal, Ooty, Kashmir, yes. If the mother is also deficient, yes. In the presence of symptoms related to vitamin D deficiency, poor growth, gross motor delay, hypotonia, irritability, and if you suspect rickets on clinical grounds with clinical features, chronic renal hepatic disease, malabsorption, cystic fibrosis, hyperparathyroidism, children who are on long-term medications including ATT, anticonvulsants, glucocorticoids, AIDS medication, etc., and obese children, adipose tissue does not have receptors for 125 hydroxy, and the storage of vitamin D is poor in these obese children. And in children with granuloma forming disorders like sarcoidosis, tuberculosis, you can screen for vitamin D levels. We know that vitamin D testing is expensive, 2,500 rupees in some labs, at least 1,500 rupees. Is there a cheap screening test? Yes, you can. If you think a child might have vitamin D deficiency, the starting point should be doing a serum alkaline phosphatase. The reason is you look at parathormones axis, you are worried about bony effects of vitamin D. So if alkaline phosphatase is normal, there's no point in doing vitamin D testing to somebody who has what looks like vitamin D deficiency. There's no need to do testing at all. If alkaline phosphatase is normal, the cutoff is very important, remember. In newborn is less than 500. In older children up to 9 years, even up to 1000 IU per liter alkaline phosphatase. If it is there, you don't have to worry about testing for vitamin D deficiency unless your lab is wrong and you have florid rickets. Routine screening should be discouraged and the high cutoff value should be discouraged. You will end up giving lots of vitamin D unnecessarily. The next burning question, should all Indian children be given vitamin D supplements routinely? And if you decide to give vitamin D, to whom do you give and what dose you give? The answers are, now there is no disagreement at all. All exclusively breastfed infants should be given vitamin D supplementation with 400 units starting from day 1 of life. There is no disagreement on this anywhere in the world. This prevents consequences of vitamin D deficiency in infancy. If an infant is formula fed and if it is getting more than 500 ml, it is very likely that most of the formulas, I'm saying most of the formulas, contain at least 300 units to 400 units if an infant receives 600 ml. But some formulas contain lower proportions. If at all you want to give, you can give 200 units rather than 400 units for those who are exclusively formula fed. When I say formula fed, it is not cow's milk, it is not dairy milk, it is infant milk substitutes in proper dilution. Preterm infants, the recommendations today suggest that you can give 600 to 800. Some authorities recommend 800, some authorities recommend 600, at least until 3 months of corrected age. Then they recommend giving 400 IU thereafter. You should exclude what is being given in TPN and other formulas. Beyond infancy, it is recommended that you increase the dose to 600 IU per day, definitely up to the end of 2 years, to prevent rickets and hypocalcemia in infants and toddlers. What about adolescent girls? Most studies in India have shown that most of the adolescent girls are vitamin D deficient unless they get a diet with fish, unless they get exposed to adequate sunlight. And if they are fully clothed, like what is happening today in COVID days, there is hardly any vitamin D which is going to get through to their skin. So it is recommended that for this high risk age group, 600 units minimum must be given. You can give safely up to 1,600 units per day. Beyond that, the risk of toxicity does occur. So the bottom line is that those infants and children receiving less than 30 minutes of sunlight or less than 20 to 30% of sun exposure 5 days a week, and if these children have poor dietary resources without salty fish, they are at higher risk of vitamin D deficiency and they need supplementation. For high-risk group, when I say high-risk group, those with chronic liver disease, renal disease, steroid therapy, obese, you can go up to 1,000 units per day. Or you can give periodic boluses, though I don't prefer periodic boluses because there is a slightly increased risk of hypercalcemia when you give bolus doses. What about the clinical manifestations of vitamin D deficiency in different age groups? This is something very important for pediatricians. There are two important groups where the manifestations are different. In infants, In early infancy, it may not be bone related. It may be related to calcium levels, seizures, tetany. They may present even with cardiomyopathy. They may present with irritability, increased sweating. Obvious features of rickets may not be there. In children, they may come to you with motor developmental retardation, rachitic myopathy, hypocalcemic myopathy, delay in walking, bony deformities, bow legs, muscle weakness, aches and pain. In adolescence, again, they can come to you with osteomalacia with pain, or they may rarely come to you with hypocalcemic tetany. You look at these pictures, they may come to you with rosary like this, or they may come to you with hot crossbun appearance with widened wrists and bow legs. They may come to you with widening of the wrist, or you may take an X-ray for an LRI and you will find like this. There is hardly any bone, and look at the torchlight appearance of the anterior ends of ribs. The upper ends of humeri, hardly there is any bone, so-called rachitic lung. They may come to you with V's, and you take an X-ray, you'll be surprised at the florid rickets you see in the X-ray. There are several unusual presentations which you have come across. The most unusual which we reported was the infant who had myelofibrosis with vitamin D deficiency, which we published. This child unfortunately died of myelofibrosis very rapidly. In addition, we have seen several infants who were diagnosed to have lactose intolerance, put on soya feeds. Soya bean feeds are very inferior in terms of vitamin D absorption and provision. Most of the soybean preparations available in India do not have adequate amount of vitamin D. So we must be very careful in ensuring that they get adequate sunlight exposure and vitamin D supplementation. Cancer recovery cases, they don't get exposed to sunlight at all. They put on weight, rapid growth period, they come back to us with vitamin D deficiency symptoms. Preterms with catch-up growth, when they grow rapidly, particularly when there are twins, they come up with vitamin D deficiency. Infants only with irritability and crying and sweating, we have found low levels of calcium and vitamin D deficiency. Adolescents with vague pain, what we in Tamil we call Kaikal Kodachal syndrome. Adolescents with tetany, and many ICU graduates and visas, particularly infants. Of course, including cardiomyopathy, quite a few cases we have seen. The next burning question, how do you treat vitamin D deficiency? There are several regimens. We used to give, I remember as a medical student, we used to give STARS therapy with oily injection of vitamin D, painful injection. Now we have stopped that. We don't give parenteral vitamin D at all. We give only oral vitamin D in most cases, except in those who have severe malabsorption. So the recommended treatment regimen, you can give any regimen you like. You can use daily regimen, you can use weekly regimen, you can use STARS therapy exceptionally. But the fundamental principle that you must remember is that it is not the regimen which matters. It is a total amount of vitamin D. The total amount of vitamin D required to correct severe vitamin D deficiency is around 3 lakhs, which you can give as weekly regimen for 8 to 12 weeks with 50,000, or you can give daily dose anywhere between 1,000 to 5,000. In general, the younger the age, the less should be your threshold for using weekly regimen and STARS therapy because of risk of hypercalcemia. STARS therapy as well as weekly therapy as well as daily therapy has been proved to be equally beneficial. Now in our unit, what we follow is a weekly regimen. We used to give 50,000, we have reduced it to even 25,000 with good results. In 6 weeks, most of these infants recover. So I suggest you can use a weekly regimen of 50,000 units weekly or 25,000 units weekly. They no need to give parenterally. They no need to give high doses of 6 lakhs, but there is a risk of hypervitaminosis. Okay. In general, in newborn, we don't use high dosage at all. We give just 1,000 units per day for about 12 weeks. But what we should remember is that whenever we supplement vitamin D to somebody with deficiency, you have to give calcium. The reason is if you don't treat hypocalcemia, if you don't supplement, the infant or the child can develop hungry bone syndrome. All the calcium will be pushed into the bone. The child may come to you with hypocalcemic seizures if you don't supplement calcium when you give high dose vitamin D. If an infant has got hypocalcemic seizures, you can use Rocaltol 125 hydroxy for a short period of 3 to 7 days to bring up the calcium. Give IV calcium, maybe 4 to 8 doses. You don't have to monitor vigorously. You can give 4 doses, then switch over to oral calcium. This is what we have observed in our experience. The last debated question, so many diseases are connected with vitamin D deficiency. Are there really good extraskeletal benefits of vitamin D to infants and children? Big debate. But the bottom line is that in pediatrics, definitely a causal association between hypovitaminosis D and nearly all major diseases in pediatrics, cancer, recurrent infections, autoimmune disease, cardiovascular disease, metabolic disorders, including diabetes in children, has so far not been established. I'm not going to talk about adult diseases because that's a different debate. But in pediatrics, definitely there is no association between hypovitaminosis D and many of these diseases. If you find that a child with that disease has got hypovitaminosis, you treat it. But don't blame vitamin D for the disease, but don't expect vitamin D to do anything to the child in terms of improvement for that particular disease. In fact, so much has been talked about vitamin D and COVID-19. I saw this article from JAMA, very interesting one, where they gave high dose vitamin D and tried to those with moderate to severe COVID, of course, adult study, and they tried to correlate the hospital length of study, and they concluded that it's of no use. So for all those indications, recurrent infections, chronic infections, your vitamin D is not going to help much, but you may give the maintenance dose if at all and never give high doses at all. My last question is there a decline in the prevalence of vitamin D deficiency? We are trying to look at it in our institution. Surprisingly, we have found over the last 12 years, we have found a marked reduction in the incidence of neonatal hypocalcemia. We have also found a marked reduction of hypocalcemic seizures coming to the emergency room when compared to the 70 cases in 2009 to only around 7 or 8 in the last year. And of course, during the COVID days, we have seen a further decline. I don't know what is the reason. It could be because of maternal supplementation of vitamin D and more sales of vitamin D drops and syrup in the market. We have not fully analyzed. I'm sure we'll be able to throw some light on it in future. With this, I will conclude saying that vitamin D deficiency is a significant problem, but most of the problems are related to bone disease rather than due to chronic diseases in pediatrics. All exclusively breastfed infants should be given vitamin D supplementation. Vitamin D supplementation, 400 units in the first year and 600 units in the second year is a must. Above 2 years, if somebody is in Kerala taking salty fish enough or getting exposed to sunlight adequately, there's no need for supplementation. For all others in pediatrics, 600 IU above 2 years may be required. Thank you very much, and I'm extremely sorry for the technical snags. Thank you very much.
Thank you, Dr. Balasubramanian, for that excellent presentation. And you have elucidated how it is a lifestyle-related disease and what is the need, how much to be supplemented, and about the extraskeletal effects. I think the participants can go to ICMR 2020 recommendations. They have also put up the tolerable upper limit in health. It is 1000 IU in infants, 2000 in children, and 4000 in adults. So mind you, those who are taking 60K every week, it will lead to calcemia and hypervitaminosis D. I think there are no questions yet, but they have many have written. It is an excellent talk. Thank you, sir.
Thank you.
So, thank you, Dr. Balasubramanian, for that excellent, brilliant overview of the topic, that is vitamin D, effectively explaining the queries in the role of vitamin D in prevention and the treatment. And thank you, Elizabeth, for chairing the sessions. So thus, I think we have come to the end of this 7th annual CME of the Gokulam Pedicon. I'm extremely thankful to all the faculties. I'm really fortunate to have such a galaxy of faculties today with us to share their expertise. And now that we have Dr. Tanu and Dr. Balasubramanian, thank you so much for being with us today. And also, I'm extremely thankful to all the chairpersons. Again, thank you, Dr. Elizabeth. And then we have Shankar, we had Riaz with us, and Dr. Shanavaz. I think extremely thankful to all of you. And also, we are fortunate to have all the IAP dignitaries, starting from the National President-elect, Dr. Ramesh, to inaugurate the function. I'm extremely thankful to him. And also the State President, Dr. Jayaraman, the Secretary, Dr. Johnny, Sebastian of the Kerala State IAP, also for being there with us in the inaugural function to offer their felicitation as well as the addresses. And also, I'm extremely thankful to Dr. Santhosh, IAP Trivandrum President, as well as Dr. Praveen, to support me in all these activities. And more than that, I'm extremely thankful to all the delegates, all the viewers, for being there with us even this time, that is even during the lunch time. It's slightly late, so I'm extremely thankful to all of you. And also now I must take a minute to thank my own personal team. I'm extremely thankful to Dr. Shaji, though he stays behind the screen, for giving me all the support, as well as Dr. Gopinathan. And more than that, I would like to extend my heartfelt thanks to my own resident, that is Dr. Shamim, for helping me with all these technical hitches. And a special word of thanks to Riaz and Praveen also for being there with me till the last end to face all these difficulties. And more than, I also place on record my thanks to Anil Yadav, as well as the Bharat of the Olympic team. Thank you, and Dr. Pradeep representing the Olympic team. Thank you all once again, and see you next year. Thank you.
Thank you, ma'am. Thank you, ma'am. We thank all the faculties and delegates who make this conference a great success. We also thank Department of Pediatrics, Sree Gokulam Medical College, IAP Trivandrum District Branch, for choosing us as scientific partners for this great event. I thank all the backend team and technical teams for making event virtually possible and smooth running of the event. Thank you, one, and thank you all. Thank you, ma'am.
Thank you. Okay, thank you, Johnny, for staying with us till the very end. Thank you.
Yeah.